boy. Okay. Testing, 1, 2, testing. Omar, did you get in?
Hello, Doctor.
Oh, you got in, Omar?
I am here, Dr. John. How are you?
Good. How you doing? You have your
Thank you.
camera today? You don't have your camera today?
What, Dr. John? Hello.
Good. I think that's recorded. That's recorded. I'm sorry about that. Let me get that off. I thought
Okay,
I had
no
it
problem.
off.
Hello?
Okay.
Hello?
Somebody has that's not my recording, that's someone else's. I'll find out though. Okay. 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 Let me turn this off. Okay, that's what it is. It was another recording I had. Okay. Okay, that should be off. Okay, finally. Omar, how you doing? Well, I guess he left. Can you hear me? Can people hear this microphone? Can you hear? Can anybody hear me? Oh, there you are, Omar.
Yeah, I'm here, Dr. John. How are
Yeah,
you?
you can hear me, right?
Okay, well, I hear you good.
Okay. There was
Thank
a
you.
good Russian webinar this morning.
Okay, I'm at the OR, operation room.
It was Sufianov of Russia. Do you know?
Yes, they recorded.
Yeah, it's on the internet. It's on the neurosurgical TV page, web page.
Yes, yes, I see it.
It's there, you can see it.
I see it's 2 hours and 40 minutes. It's
Yeah,
very
it
nice.
was, yeah, they had a 3 hour.
Mm,
I didn't
yeah,
know
it is.
about it. I found out about it in the last minute. Here, let me.
Let's see how that all. Let's see nearly 1 hour, not completed.
Okay.
Complete later.
Okay.
Okay, thank you.
Yeah.
I am with you now today. I am now free.
Okay, I'll change. How's everybody doing? Change that. Oh, Lim, how you doing?
How are you? Can you hear me?
Good. Yeah, I can hear you. I'm trying to see you here.
Oh, great.
Yeah, let me get off the pin here.
Yeah, I am the
Okay.
first speaker.
Okay. Oh, great.
I'm
great.
ready.
Welcome. Do you have any questions? You want to test anything or something? Because I don't have your camera on. You know, camera's not on. Or Dr. Lim?
Yes.
Yes, you can. Can you put your camera on, please?
Oh, camera.
Oh, you're not even in. Okay, okay. It should be better now. I'm sorry, you weren't even in.
Hi, John. How are you?
Hey, Arshad, how you doing?
I'm fine. How are you?
The star students here. Hi, there's
Yeah.
Dr. Lim. How you doing? Okay, you gotta unmute there, unmute. You're muted. Dr. Lim, you're muted.
Okay.
Well,
Yes.
very good. Nice to meet you. I'm Dr. Bennett. There's a few people here. Hey, Arshad,
Yeah, hi.
this is Dr. Lim. He's giving the first presentation.
Yes.
Hello, Dr. Lee. How are you?
I'm fine. How are you?
I'm Dr.
Arshad's
I'm
from,
okay.
From Mumbai, India.
is your
Yes.
camera working?
I know.
Hi, Dr. Omar.
Hi, Dr. Harshad. Dr. Lim, how are you?
This is Omar
I'm
from
fine. How are
Syria.
you?
From Syria.
Syria.
Anybody
From
else
Syria.
want to say hi to Dr. Lim? Zainab, how about you in Africa?
I'm fine, thank you. Greetings to everyone.
Say hi to Dr. Lim. Dr. Lim, she is from, what the country you're from, Zainab?
The Gambia, West Africa.
Gambia
Yes,
in
sir.
West
Wow.
Africa.
Mhm.
And you're a resident, right? You're a student or a resident?
A resident.
Resident.
Yes, sir.
Okay, very good.
Mhm. Thank
You
you, sir.
frequently attend these. You're being a good student.
Yes, sir. I learn a lot
Yeah.
from this platform. That's why I love it.
Do you have any questions, Dr. Lim? Do you have any videos or anything you have questions about? Hey, Sam.
Hi, John. How are you?
Good morning.
Hello, Hassan. Dr.
Professor,
Hassan.
Professor Khan, how are you? Thank you for accepting my invitation.
Thank you. Inviting me.
Hi, Sam. How are you? Dr. Harshad Parekh from Mumbai.
How are you, Dr. Harshad?
I'm fine. All great. You're doing great job.
Thank you, sir.
Sam, some of the regulars are here. Omar's here from Syria.
Yep. How are you, Dr. Omar?
الحمد لله دكتور سامي. How are you? كيف مصر؟
الحمد لله بخير.
الله يخليك يحفظك يا رب.
الحمد لله.
تحياتي الله يخليك.
شكرا جزيلا.
And Zanab is here from West Africa. Hello, Zanab. Say hello to Sam.
Good day, Dr. Sam.
How are you, Dr. Zainab?
Fine, thank you, sir.
Nice to
How are
meet
you? It's a pleasure,
Nice to
sir.
meet
It's a pleasure, sir.
you. Abby, how are you?
How are you?
I'm
Hey,
fine.
Abby.
Hi,
How's
John.
it going? How's it going?
Yeah, it's going okay.
Good, good, good. This is Dr. Lim, Abby.
Yes, I'm ready.
Abby is the neurosurgeon from Mumbai. She helps a lot on these telecasts.
Hello, Dr. Lim.
How are you?
I'm good.
Dr. Ahadi, I still
Hi,
remember.
Zainab. Hi,
How are you,
Zainab. How are
sir?
you?
Fine,
I'm
thank you,
fine.
sir.
I'm fine.
I still remember the anatomy of the cerebellum. I still can't forget it.
Okay, good.
Thank you, sir.
She's a frequent user of the webinars. That's good. Okay, Sam. So, Sam, are you there?
Yep. 2
Yeah.
minutes
So,
to start.
Sam. Okay, the videos are going to be after the third speaker, right? Third and fourth speakers are going to be videos.
No, 6 and 7.
I'm sorry. What?
6 and 7.
3 and 7.
6.
Oh, the end. 6 and 7.
Yep.
Okay. Well, just let me know. Just text me. Okay. You can always
Okay.
in the tech in WhatsApp or this text. Just let me know ahead of time. So
Okay.
I'll just know.
John, could you make me a co-host?
Oh yeah. I'm sorry, I forgot. And Abby, you want to be her co-host? Very
Yeah, you can
prestigious.
make me go.
Very prestigious on your resume.
Yeah, but maybe after a couple of hours, the co-host will sleep. I'm not sure, but yeah, you can make me go.
Well, that's only if we all get in the plane crash. You're gonna have to take over.
Yeah.
Sam, who else is gonna be? It's background noise for me, my street. Marco, hey, Marco, all right. Haven't seen him in a while. Marco, can you hear me?
Hey, buddy, how are you?
Hey, Marco, how you doing?
I am pretty fine, thank you.
Long time no see.
Yeah, I was very busy.
Yeah. Okay. Well, welcome.
Thank you. Hello, everybody.
Okay.
Hello, Marco.
So you've been real busy, huh?
Hmm?
You've been real busy, and how are things with COVID? Pretty died down in Italy.
Sorry, can you?
Is the COVID kind of quiet in Italy?
Yeah. Fortunately, is under control. We got a lot. The most part of population vaccinated, so we're doing very well, and we restart the surgery, the daily surgery without any problem. So maybe some arrangement about the procedures. Example, check the COVID by test in every patient that came in hospital, but about the activity, we will start in a very well fashion, I guess.
That's very good. I'm glad to have you here, Marco. Okay, let's see, Sam, where are you at? We're going to start in about a minute, Sam. Are you ready? About a minute, Sam?
Professor Goel, how are you?
John, yes, how are you?
Hey, Sam, how you doing, Atul? The king
Very
is here.
good.
Proceeding starts.
Yes. Sam, best wishes to you, and I hope everything will be okay for you.
Thank you, sir.
You're speaking second, right, Atul?
Yes, yes,
Okay.
yes, John.
We can start now, John.
Okay, here we go, Sam. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Hi, this is Dr. John Bennett of Neurosurgical TV. We're honored to be hosting the Spine Revolution, another Samuel L. Morsi EWNC collaboration, and I'll turn it over immediately to Sam. Good day, Sam.
Good day, John. Dear friends, welcome again to another revolution of EWNC Academy. This time we will talk about recent concepts on spine surgery that may make in the future another revolution. And we will start by Professor Lim. Please, sir, go ahead. Thank you. Professor Lim, please start sharing your screen.
All set, Dr. Lin?
Should I start?
Yes, please.
Okay. Can you hear me?
You're on the Zoom screen now, so you better change your slide there, I think.
Okay.
Yeah.
How are you, everyone? My name is Lim. I'm a neurosurgeon in Korea. It's the local time.
I'm sorry to interrupt Dr. Lim again. You're not showing the screen at all. I'm sorry to interrupt. Okay, that's on there. Make it bigger, please.
Okay.
Presentation mode.
Yes. The Korean local time is the 12 of the midnight. Okay, my name is Lim, neurosurgeon in Korea. Thank you. It's a great honor to be invited here. I will start. I will talk about the current situation of endoscopic spine surgery. Let's find out what kind of change will happen in spine surgery and what can we do with endoscopic in spine field. It's my disclosure, laminectomy and foraminectomy for the stenosis was practiced during the beginning period of a new endoscope surgery. After that, there has been huge increase, significant advancement in endoscopic spine surgery.
Excuse me, the audio is terrible. Could we please fix it, Dr. Lim?
Conducted in my work cases are 100% endoscopic surgery now. Endoscopic spine surgery provides a wealth of benefit for spine surgeon and patient. We can perform operation with local anesthesia under the good visualization of endoscopy. post-operative infection rate is very rare, even multiple level operation. Fusion surgery can be avoided with delicate nerve decompression of endoscopy without damage of post ligament complex. Not to damage and not to detachment of post ligament complex in endoscopic surgery are important factor in the maintenance of spine stability. Is different from open surgery.
Excuse me, Dr. Lim.
In terms
Sound
of
is not good.
important fact of endoscopic spine surgery is that it enables them to change direction quickly from ipsilateral to the contralateral in narrow spinal canal. It's the same like the journey across the Nile River from the west to the east at high speed. And lens angle is important. The technical lens angle provides the smallest detail than wide angle lens in spinal
John,
canal
audio is not good.
endoscopic operations. The technical lens angle endoscopic
Dr. Lim, Dr. Lim.
is
Good. The audio is not good.
close to the
Is there any way we can improve it?
wide angle lens. And
Dr. Lin, can you give a lecture
Yes.
rather than recorded? You don't use the recorded version. You please talk with your slides. That may be better.
Could you please turn the audio off and comment yourself?
How is that? The sound?
Yeah, no, Dr. Lin, can you give a lecture? Don't use the recorded version. You talk. You use your slides and talk. Your recorded version is not clear.
Agreed.
Okay, please change it. My turn.
Yes, you
Yes.
talk now.
Yeah, please talk on your lecture. Yeah, we'll just edit this. We'll start
Okay.
again.
Our talk about.
No recording, please.
Okay.
Just by voice, your voice, live.
Can I change my turn?
Yes, now it is okay. Dr. Lin, now it is okay.
Okay, you can start.
Because I need to.
Okay, no worry.
Okay. Remove the record.
Yes.
Okay, it's okay.
Yeah, very good.
Okay, I will talk about the current situation of endoscopic spine surgery in Korea. So what can we do with the endoscopic in spine field now? As I disclose, so we extended endoscopic surgery from the stenosis, laminectomy and discectomy, and we can do the fusion surgery, transforaminal interlaminar fusion for lumbar and the HDF. So the operation in the spine surgery is 100% endoscope surgery. Sorry, my voice has changed due to the seasonal flu. It's okay. And you know very well the advantage of endoscope surgery that we can do
the endoscopic surgery under the local anesthesia, and endoscopic surgery that provide good visualization and clean. We can use water irrigation. And infection, post-operative infection rate is very rare, even though the multiple pathology lesion. And you can do the endoscopic surgery the way the less damage of a muscle and the facet joint and posterior ligament complex. And so most important thing is we can preserve the posterior ligament complex. Is very important to keep the spine curvature. And we can do endoscopic surgery from the ipsilateral to contralateral decompression, like a journey from across the Nile River from the west to the east. And the more important thing is endoscope. We have a 10-degree lens angle. 10-degree lens angle provide a more detailed surgical view, so we can do the ipsilateral decompression more easier than the wide lens angle. And we can save the facet joint. The preserved facet joint is very important. If we turn the endoscope surgery, it's totally different the side, and we can do ipsilateral decompression. And a post-operative MRI shows the full quite enough decompression with minimum bone work, and we can say you can preserve facet joint and muscle. We are the aging society. We can expect the frequency of the spine surgery to increase with the age. And we have the risk in case of big open surgery, big open spine surgery, the heart and brain and some the problem under the general anesthesia and the big operation. As the case is one level patient had the one level the lumbar stenosis L4-5, and with the endoscopy we can decompression from ipsilateral to contralateral side without the bleeding. Post-operative MRI shows full quiet enough decompression. And the two level, L4-5, L5S1, we can do decompression with the safety. Post-operative MRI shows the full decompression. It's a 3-level, 2, 3, 3, 4, 5, 3-level decompression, 3-level stenosis. Post-operative MRI shows the quiet enough, and right after procedure, patient can walk just with a 7mm scar. Just one skin port, we can do 3-level decompressions. It's the animation of 3-level decompression with one skin port. It's a jumping technique. First the midline, and then we can do adjacent level, 1 by 1, 3-level. It's a jumping technique. It's my paper about endoscopic surgery for the lumbar stenosis. And the patient have the 4-level central stenosis and the 2-level the foraminal stenosis. What should we do? Do you want to perform the fusion surgery? So we can do 4-level interlaminar approach, 4-level decompression with one skin port, and 2-level foraminotomy with one skin port, another one skin port. So it's drain, the foraminoptomy 2 drain, and the interlaminar approach 4 drain. Patient have 6 grenades, 6 drain. If we can create the multiple tunnel for the lumbar stenosis, we can avoid the fusion surgery. But sometimes we have to perform the fusion surgery like this. Patient have the unstable L4-5. It's important. It's not impossible to treat for this patient with endoscopic decompression. We need to perform the fusion surgery. Post-operative X-ray MRI shows the stable, and we can do the endoscopic fasciectomy and discectomy. We can insert allobone graft and the implantation. The small scale scar. So all process means using by endoscopy, discectomy, that we can use shave, and we can do allobone graft and the cage insertion. It's a final stage. It's endoscopic the surgery to provide clean surgical view like this. From the 4 centimeter from the midline, we can do fasciectomy and discectomy allobone graft and implantation, and we can insert the pedicle screw like this. Allobone graft and the cage insertion. The cross-sectional area, we can post-operative MRI shows the widen the spinal canal and the direct indirect decompression, and the bone graft area, the ratio is better than the mini open surgery. And the disc height and segmental lumbar lordosis, bone graft area ratio, and the fusion rate is better than the mini open tree. It's my paper about the comparative study of bone graft area and the fusion rate in the unilateral transforaminal interbody fusion between endoscopy and mini open surgery. And let's talk about the cervical lesion. So we performed the HDF and open posterior decompression for foraminal stenosis and foraminal disc and laminoplasty for multiple level, the OPLL. But we can do endoscopic decompression for the cervical lesion. It's the 1 level, the paracentral and foraminal disc. You can do the foraminotomy, and we can expose, decompress the root, cervical root, posterior decompressions. It's a motor root, sensory root, like this. The foramen is located just below the facet joint. The landing point is the medial board of lateral mass that we can do laminectomy and the fasciectomy for decompressions. And if we want to, the contralateral approach is possible. It's the posterior decompression. Cervical is from the C6 and C7 laminectomy, and we can expose cervical root and the final cervical root, it's a disc space. And we need to consider the instability and the posterior decompression and the kyphosis in case of the open posterior decompression. But endoscope surgery that can preserve posterior ligament complex. So in case of the widened the laminectomy and the facetectomy, there was no instability and kyphosis post-operative 2-year more follow-up. And multiple level, the stenosis, the patient have a 3-level central stenosis. We can do with one skin port, we can perform 3-level decompression. It's the sliding technique for 3-level decompressions. The adjacent segment in the cervical is very short, so that's why we can do the sliding to each segment. We can decompress with one skin port. And the post-operative MRI shows the full decompression. And so we perform the laminoplasty with the damage of posterior ligament complex. It's endoscopic decompressions. Pre and post-operative MRI shows full decompression. And the axial view post-operative MRI shows the widen the spinal canal. And the 2-year follow-up X-ray shows stable, no kyphosis, no instability. And the 4-level cervical decompressions with a 2 jumping, 2 sliding technique. And we performed the endoscopic surgery for high cervical region. Before we performed the high cervical region in case of the rheumatoid panus, inflammatory, and pseudotumor in the high cervical region with the open surgery. In my case, I see 2 root decompressions. No instability, X-ray shows no instability on flexion extensions. The endoscopic placement, endoscopic system between C1-2 region also. And we can do C2 decompressions. It's a panus, the formation tissue, we can remove. And decompress C2 root. The Pesca zone is the landing point between the rectus capitis posterior major and the obliquus capitis inferior. Before the operation, we need to check the vertebral artery course to prevent damage of vertebral artery. And case 2, next case is C1-2 myelopathy due to the pseudotumor. The MRI shows the huge anterior mass and posterior the compress of cervical spinal cord. And X-ray shows no instability. The post-operative MRI shows the decompression quite enough, and the axial view also, the widened spinal canal with the endoscopic laminectomy without the fusion surgery. And we are we want to focus on the endoscopic HDF. The young male patient have the huge central type, the disc C5 or 6. It's impossible to approach the posterior approach for decompression. So we had to anterior approach discectomy. You can the landing endoscope system on the surface of anterior discal space, and we can do discectomy. It's very clear the endoscopic the view, and we can see the dural pulsation here. After removal, PLL, and we can do implantation. And the final stage, we need to keep the drain to prevent post-operative hematoma. CT scan shows the drain, and we can use a Harrison punch and the post-operative X-ray, and the MRI shows the decompression, and the skin scar just 1.5 centimeters is enough. And the 1 year follow-up, the X-ray shows stable, no migration of implantations. And we can use endoscopic the system for HDF, just 8 millimeter the diameter endoscopy, and we can use 1 to 3.5 millimeter Harrison punch and the drill. As I mentioned, the 10-degree lateral angle is very important because we can watch the ipsilateral uncovertebral joint more detail than the wide range angle. And gently push the anterior visceral organ with the one finger, and we can insert needle and the endoscope system and the different the skin scar between the microscope and endoscopy. And male patient have right arm weakness, and you can see the spinal cord high signal and the calcified the disc myelopathy. The first, we need to resect the anterior osteophyte to create the pathway to the disc space, and then we need to resect the posterior osteophyte for decompression, and then finally we have two implantations. Post-operative MRI shows the full decompression of a spinal cord. CT scan shows also good post-operative decompression state. And there's a video after remove PLL, you can see dural pulsation before the implantation. And it's a very interesting case. The patient have the anterior disc, the herniation disc, and the posterior, the buckling or ligament flavum. We had to, I had to perform the posterior decompression first, and then anterior approach HDF at the same stage. I've been the CAIRO twice. It's a photo in 2016. As I mentioned, posterior decompression first, and then HDF anterior approach. As we can see, the spinal cord, after the finish, the posterior decompression, and we can see dural pulsation with the anterior approach, before implantations. Post-operative MRI shows posterior decompression and anterior HDF. To widen the spinal cord, posterior decompression and anterior HDF. So it's 8 millimeter, the pico case, and we can see the posterior, the drain, and the anterior, the drain. That we can do endoscopic ADR also. As a dura injury and the root injury is the most scariest moment in all the spinal operation. What we can do, we can seal in the dura with a taco seal, the fibrin patch. It's my paper about how to manage in case of the durotomy during the operations. I think the challenging is always the scariest moment always, but we have if we have a new weapon with a new idea, we can overcome this. Learning endoscopic is not easy. Learning endoscopic spine surgery is not easy to the surgeon, but I think it's very rewarding and worthwhile. Okay. We have the spine fellowship program in my hospital. So if you want to visit my hospital, please let me know. It's my email. Thank you. Sorry, my voice has changed because seasonal flu, not corona. Sorry, my voice is husky. Thank you.
Thank you, sir, for this excellent presentation. Is there any question from panelists?
Yes, I have a question. Thank you very much for your presentation. I want to know, just for a follow for your case for cervical pain. I see that the cage are higher. In my experience, when you do that, there are decomposition of the other segments. Are you agree with that or not?
Sorry, again, please.
Did you understand that question? Sam, did you understand the question, Sam? Could you repeat it?
Okay. The cage are higher. Cage.
Cage, the higher. Yeah. Higher. Height.
Yes.
Is there any
I use, we can use the cage from the 5 millimeter to 8 millimeter. So the process is same like the open, the HDF.
Yes, I want to say that the 8 millimeter is very high for cervical spine because there are decompensation of the other segments. So in our series, is there decompensation or not? No.
Sorry, I can hear you.
I say in your series, is there any decompensation for the other segment, cervical segment, adjacent to the segment operated segment?
It's means 2 level.
No, so I will write it. I will write it. I send you.
Okay, you're gonna
The
send him a
endoscope-
message, Said? Okay, send him a
Yes,
message, yeah.
Message, yes, okay, thank
Okay,
you.
Said.
I will make it more clear. Say when you use a big cage, size 8, is there any decompensation in your series?
Well, I think we'll have to rely on the text.
Okay, okay.
Okay, Sam, let's move on. Thank you, Dr. Lim, thank you.
So we have
Yes.
No.
It's more.
Yeah.
Yeah.
Can
Endoscope
I ask a
spine
question to
surgery.
Dr. Lim?
Okay. Endoscope spine surgery is the same like the open surgery. Just we can use the endoscopy instead of a microscope. Right? All the process, everything is the same like the open microscope surgery.
Okay, thank you very much.
Can I ask a question to Dr. Lim, please?
Yes. Yeah.
Yeah, I'm Dr. Brigadier Swami, Professor Brigadier Swami. I'm from Jabalpur. I just want to ask, you have used ADR in the sense to put the ADR, you have to make the same amount of incision because it's a bigger cage. So what is the point of using just endoscope? It's just improving the vision, or it's got no advantage over the microscope, isn't it?
In case of the ADR.
Yeah, the incision is same, approach is same.
Yes,
probably you have a wider vision when you use microscope, except that that you are putting endoscope as an endoscope assisted one. It doesn't offer. It's not purely endoscopic, as you said in the initial thing.
Yes, all the process is the same like the open surgery. And the first, we need to insert the cage holes into the endoscope, and then we can fix the ADR or the pico cage, and then we can insert. We can do the implantation.
Okay, you're not getting what I want to say. It's okay. The second thing what I want to say is he used a lot of animation in doing the posterior foraminotomy, especially bilateral, and you said you can go for 3 level. I wish you had shown your own clips, because animation is quite impressive. But when you do,
thank you.
Yeah.
Thank you. And so if you have the question, send a message.
Okay, thank you.
Okay, thank you.
Okay, thank you, sir. There are other questions in question box. Could you please answer it by writing? Okay, we will shift to next speaker, Professor Guel, is my dear friend and an eminent neurosurgeon and spine surgeon. Please, sir, go ahead. Thank you. Thank you, Professor.
Okay, Dr. Samay, my dear friend, and it is my great pleasure and a big honor to give you this presentation, and you have given the title Revolution. So I am going to present a revolution in spine surgery, not revolution in technique, not revolution in instrumentation, but revolution in philosophy, revolution in concept. And I introduce to you a new concept. And I look beyond decompression. Whenever any spine surgeon is talking, the main issue remains compression is the problem and decompression is the treatment. I am introducing a new concept, a revolution, that compression is never the issue and decompression is never the solution. So looks quite dramatic, looks quite dangerous, but let me give you this presentation, and I hope I can convince at least some of you. So the concept is, for majority of, you can hear me, Samay, right?
Yes.
Okay. The concept
is there's some echo.
Some echo is there, John?
Yeah, okay, hold on.
Okay. So my concept is, for a number of issues, instability is the problem and stabilization is the solution. It is not decompression of compressed structure that is the issue at all. So that is the question. So the main issue in the human body is that we have a standing human position. Like no other animal in the universe, our muscles of the back are strained or stressed throughout our life. Like in a bird, the muscles are in the wings and in the shoulders. In a four-legged animals, it is on both the basis of both legs. There is the problem is, if at all there can be a problem, it can be in the legs, in the wings. But in the human body, it is the muscles of the spine or the back which can be a problem. So all the muscles of the human body are located in the back. There is hardly any muscle in the front of the spine because of the extensor dominance of the human body and the standing position. So what happens in the human body because of the standing position throughout life? There is a telescoping of the spine or vertical fascital instability, which leads to degeneration of the spine. So that is my concept, that standing position leads to telescoping of the spinal segments, and that leads to vertical spinal instability that cannot be seen by radiology. MRI will not show you that instability. CT scan will not show you because the instability is vertical and it is fascital. So these are the two things which I will like to discuss. So as I mentioned to you, the entire human spine is posterior or extensor prominent or predominant. Anteriorly in front of the spine, there is hardly any muscle. There are only longus colli, which are very thin and flimsy muscles. So most of the activity or the entire activity of the human spine is based on the posterior muscles, and they are focused on the facets. The most mobile segment of the spine is craniovertebral junction or atlantoaxial joint.
Mặc quần áo tay dài, nhớ chưa? Rồi. Phải mặc quần áo tay dài.
John, there is some nice voice coming from behind. Is that some problem? John?
It's okay, sir. It's okay.
Okay, okay. So the whole body, the muscles are located in the back and they act on the facets. And the most mobile segment of the human spine is atlantoaxial joint. The other concept which I want to mention before you is more the mobility, more the possibility of instability. More mobile is the region of the spine, more potential of instability. So atlantoaxial joint is potentially the most unstable joint of the body. I have no hesitation to say that atlantoaxial instability is the most common form of instability in the entire spine. I have no hesitation to say that the atlantoaxial instability is the most under-recognized and under-treated clinical entity by spine surgeons. The facets are the issue. Not issue. Disc is divine. Disc can never be a problem. That is another very major issue which I will discuss. That disc is never a problem. Don't do discoidectomy unnecessarily. Instability is the issue, and instability is focused at the facets. So before I go to subaxial spine, I want to discuss about craniovertebral junction. Many of you may not know that about 25 years ago, basilar invagination was treated as a fixed anomaly. Odontoid process going up, we classified into two groups, odontoid process going up and tonsil coming down. These were the two groups. And in 1998, I described myself that this group needs transoral decompression and this group needs foramen magnum decompression. So that was my understanding in 1998, that instability is not the issue. Instability was not considered a problem. Compression was considered a problem in 1998. In 2004, we said that group A, the odontoid, when it goes up, it is an unstable spine and it does not need decompression. It needs craniovertebral junction realignment. So we said that decompression is not required for group A. In 2004, we said that group B requires decompression for Chiari malformation and for basilar invagination. So we changed for group A. And since the year 2000, we have got several hundred cases where we have not done any form of decompression. We have done craniovertebral junction realignment and more than realignment, stabilization. So instability is the problem and stabilization is the treatment. Decompression is not the treatment. That is what we said. This was the first case in the year 2000 where we did not do any transoral decompression. We did open the joint, distract the facets, and realign the craniovertebral junction. There is no decompression. So we have got several hundred cases with this kind of issue where we have not done any decompression. And I am absolutely convinced that for basilar invagination, decompression is a negative form of treatment. Instability is the issue. Do not remove any bone. You remove any bone, you increase the instability. So instability can be increased by your decompression. Do not do any decompression. Rotatory dislocation was considered to be a fixed kind of anomaly, and before this article which we wrote, the whole world was doing decompressions for this kind of anomaly. We introduced the concept that you open the joint, realign the craniovertebral junction, and you can give a beautiful face and beautiful smile and beautiful power in the lips. There is no decompression necessary. Even for this boy, he has lost his wonderful hair, but gained a little bit of a smile and a little bit of straightening of neck. No decompression, stabilization is the treatment. Open the joint, manipulate the facet, realign the craniovertebral junction. This concept has completely revolutionized craniovertebral junction surgery for sure. And many people in the world who are focusing their attention on craniovertebral junction know how to do realignment. Many of you may not know of this entity, fixed atlantoaxial instability or fixed atlantoaxial instability. This was a very commonly discussed issue about 25 years ago. So this article of mine, which was published as cover page of Journal of Neurosurgery, we said that there is nothing like fixed atlantoaxial instability. You can reduce the instability by manipulation of the facets. So this is fixed inflection and extension. There is no movement in the odontoid process. Open the joint, realign the craniovertebral junction. Essentially, we said that there is no need for decompression in these cases. These are unstable spine and stabilization is the treatment. So similarly, this is another case where there is, otherwise the whole world was doing transoral decompression and many of the people in the world were doing foramen magnum decompression. No decompression is required in such cases. And this is quite a change in the concept. So the concept is basilar invagination, instability is the problem and stabilization is the treatment. That is the concept. And there is no hesitation to say that we completely demolished transoral surgery from the domain of craniovertebral junction in general and basilar invagination in particular. Standing human position and lumbosacral listhesis we all know. In the year 1999, we said that there is listhesis of C1 over C2, which is due to unstable craniovertebral junction. Basilar invagination is instability, and basilar invagination is listhesis of C1 over C2 in 1999. And accordingly, we treat it like this is basilar invagination, Chiari malformation, syringomyelia, basilar invagination. Listhesis is the problem. Realignment is the solution. There is no role for decompression in this operation. Absolutely, it should be clear. Then we introduced an absolutely revolution in spine surgery, in craniovertebral junction surgery. And I want to give you this revolution, which Sameh likes to call revolution in spine surgery. This concept of central or axial atlantoaxial instability, if you read between the lines, central or axial atlantoaxial instability is present in all cases of Chiari malformation, syringomyelia, cervical degeneration, OPLL, Hirayama disease, and I will like to discuss all these things and in relation with instability. So let me show you first type 1 instability, listhesis of C1 over C2. Listhesis of C1 over C2, there is atlantodental interval disturbance. We know this. When only parameter to describe instability in the literature is atlantodental interval disturbance. So there is compression of the cord, there is listhesis. So we said that there is no need for decompression, you do stabilization. Now you see another one. Type 2, facet of C1 is behind facet of C2. There is no atlantodental interval disturbance. There is very severe basilar invagination. I have to tell you that the whole world, even today, will do foramen magnum decompression for this. And I have no hesitation to say that foramen magnum decompression is a negative operation in this situation. Instability is the problem and stabilization is the solution. C1, C2 instability is the issue and C1, C2 stabilization is the solution. So this is type 2. There is no atlantodental interval disturbance. Now I want to talk about type 3. There is no atlantodental interval disturbance, but there is assimilation of atlas. There is Chiari malformation. There is syringomyelia. All these are secondary events, and all these indicate atlantoaxial instability. Even when the facets are in alignment, you do atlantoaxial stabilization and you see an absolute magic. Magic in return of syringomyelia to normalcy, more than anything else, magic in the clinical condition of the patient. I have no hesitation to say that decompression in this situation will be a negative operation. So basilar invagination and instability there is no question. And all types of basilar invagination, whether it is group A, whether it is group B, atlantoaxial instability is the issue and atlantoaxial stabilization is the solution. Another thing I want to mention, inclusion of the occipital bone and the subaxial bones in the fixation construct are negative operations and should not be done. So there is no atlantodental interval disturbance. There is fascital type 2 malalignment. I call it axial or central atlantoaxial instability. There is Chiari and syrinx. There is no question in my mind that decompression, which is done all over the world, is a negative operation for Chiari and syrinx. Instability is the issue and stabilization is the solution. You do this. It is not an easy operation. Problem is, if it is not easy, does not mean it is not correct. Atlantoaxial fixation is the solution, and you see the magic in syrinx in 100% of cases, and more than anything else, magic in the clinical condition of the patient. Even when there is no atlantodental interval disturbance, even when there is no fascital malalignment, presence of tonsillar herniation is an indication of an unstable atlantoaxial joint. There is no tight posterior fossa. This entity of tight posterior fossa was introduced by me in 1998. I said in CAIRO and basilar invagination, there is tight posterior fossa and decompression is the treatment. Today, I say that decompression is a negative form of treatment. Atlantoaxial stabilization is the treatment. So syringomyelia, CAIRO malformation, you have, if you want to see the magic, you have to learn this atlantoaxial fixation. Fascital instability may be present or may not be present. All these assimilation of atlas, CAIRO formation and tonsillar herniation and syringomyelia are all secondary to atlantoaxial instability. So what I'm saying is, when there is chronic atlantoaxial instability, there are many naturally protective maneuvers which God does, and which I will show you what the God does. You see there is syringomyelia, tonsillar herniation, only fixation, and you see the magic of syringomyelia God. This is another case. You see how the syringomyelia has reduced after surgery. So basilar invagination, CAIRO formation. I do not like to call it CAIRO malformation. It is a divine intervention. It is a naturally protective phenomenon, this tonsillar herniation. Atlantoaxial instability is the cause, and atlantoaxial stabilization is the treatment. And I have no hesitation to tell my dear friend Sameh that this is a revolution in the treatment of CAIRO malformation, in the treatment of basilar invagination, in the treatment of syringomyelia, and a treatment of many other problems which I will discuss. So we recently presented our work with 388 cases with remarkable clinical result, remarkable. Syringomyelia resolved in remarkable number of cases. I wish you can read this article to know the exact details. So CAIRO is not a malformation, it is a formation, it is a nature's airbag. It protects in cases of potential or atlantoaxial instability against damage to the spinal cord. So it is a natural airbag, potential or manifest atlantoaxial instability. So when there is atlantoaxial instability, many things happen. One is CAIRO, I have discussed, syringomyelia, I have discussed, cervical fusions happen. And these are all protective responses to instability. They are not abnormal. Bifid formation is a dynamic phenomena. It is not a problem. It indicates, when there is bifid, it indicates atlantoaxial instability, even when the dynamic images are not showing instability. You see, there is no instability here. There is no compression here, but there is fusion of multiple segments. There is bifid here. So these are clear indicators of atlantoaxial instability, and you have to. There is no other solution. You cannot do any osteotomies here or decompressions here, which will be negative operation. Atlantoaxial instability is the cause, and stabilization is the treatment. We said in this beautiful article that os odontoideum is a natural, is a divine section of the odontoid process. In the presence of atlantoaxial instability, there is no need for any transoral decompression, which will be negative operation. I must tell you, my dear friends, transoral decompression is still done in many parts of the world for os odontoideum. There is no need for occipitoaxial fixation. It is an indicator of atlantoaxial instability. It is an indicator of need for atlantoaxial stabilization. Syringomyelia is not harmful. It is helpful. It is secondary. It is divine intervention in the presence of chronic atlantoaxial instability. I have no hesitation to say that we have demolished the surgery of syringoperitoneal and syringosubarachnoid shunt. And whoever will do will certainly refer to my articles on the subject where we have said that they are negative operations. Idiopathic syrinx, nobody in the world knew what to do. Decompression and shunts were the only treatment. We introduced the concept that this is not primary, this is secondary, and decompressions are not necessary, stabilization is necessary, and you will see the magic in syrinx, and more importantly, magic with the patient. Long-standing musculoskeletal issues in basilar invagination, like short neck, torticollis, platybasia. You see this short neck, torticollis, platybasia, bifid, clipal file abnormalities are not primary events. They are not congenital abnormalities. They are not embryological dysgenesis. They are due to one problem, and that problem is atlantoaxial instability. You stabilize atlantoaxial joint, and you see the magic. You see this beautiful smile. You see this long neck. There is no need to do any osteotomy in torticollis. Even if there is no smile in this child, there is beautiful neck and beautiful hands and legs. Not only this child has got a new life, the whole family has got a new life. And believe me, understanding the fact that atlantoaxial instability is primary and this is secondary, and this is protective, and this is naturally divine intervention has great meaning to the understanding of this subject. Another beautiful thing I want to show you, beautiful, and you please see this. This patient of kyphoscoliosis, the whole world will go and introduce screws on multiple levels, and big, huge rod were measuring more than 1 kilometer in length. But many situations, atlantoaxial instability is the primary cause. Chiari malformation, syringomyelia. You treat atlantoaxial instability. You see the magic in the patient. He will start breathing properly. He will start talking properly. He will start jumping properly, and he will have a beautiful straight spine. Even if it is not completely straight, he will be completely relieved of his pain. This boy has never slept supine in his life. In the immediate post-operative period, he will sleep supine and he will be relieved of all his symptoms. Kyphoscoliosis, we must not neglect craniovertebral junction. This is another article on the same subject, that dorsal kyphoscoliosis, atlantoaxial instability can be the cause. Syringomyelia, when it is present, no question. Chiari, when it is present with kyphoscoliosis, no question. But even when they are not present, these bone fusions will indicate atlantoaxial instability. Assimilation of atlas will indicate atlantoaxial instability. You stabilize the joint and see the magic. The question is, do you have the potential of doing this difficult operation? If you do not have, you have to learn. I know many of the people who are watching are young, enthusiastic neurosurgeons, and I wish they get my message. They don't see ego and arrogance in my statement. They see the potential of revolution in these statements. So these kind of kyphoscoliosis, do not jump with multiple screws and multiple rods. You do atlantoaxial fixation, and this patient, there is a potential of complete cure. You can give beautiful smiles to this patient. You can make a king out of these children if you know how to do atlantoaxial fixation. Also, you know, sometimes central or axial atlantoaxial instability, patient comes with myelopathy. There is no other symptom, no other issue. There is no compression. There is no evidence of any compression, but you see there is bifid here. You see there is syringomyelia here. These are indicators there is central instability. These are indicators of atlantoaxial instability. You stabilize and you see the magic. You stabilize atlantoaxial and subaxial spine in selected cases, and you have a potential. You see, this hand was not going up, and this is in the immediate post-operative period, the hand has gone up. You see the shoulder drooping down. In the immediate post-operative period, you see the shoulders returning back to normal. So now I'm saying for sure, I'm saying definitely, I'm giving you a revolution that foramen magnum decompression can certainly become a historical operation. In my understanding, it has already become historical for last 15 years. Now I go to similar concept I used for subaxial spine. And I want Samay, you please try to understand what I'm saying. And I'm going to present to you a beautiful revolution in subaxial spinal understanding. We know about anterior approaches to cervical spines, spondylosis. We all know. And I have done such cases on multiple occasions, multi-level decompression and fixation. Many a time I used to do decompression without stabilization. The whole world is doing. We introduced this beautiful tricortical screw fixation. So in short, I was doing a lot of anterior surgery once upon a time, not now. So you will ask me what I do now, and that I want to show you. If you read the literature on degenerative spine, the whole spine concentrates on the disc. The whole spine says that there is age-related reduction in the disc space and disc herniation due to age-related disc degeneration. I am saying that disc can never go wrong. I said earlier that the whole spinal muscles are focused on the facets. When the muscles become weak, there is a fascital instability. Nothing happens to the disc. And I want to elaborate on this subject. Majority of my understanding of subaxial spine has come from craniovertebral junction. And we wrote this article 11 years ago about my experience with degeneration of craniovertebral junction. Believe me, my dear friends, degeneration of atlantoaxial joint has never been discussed in the literature. Believe me, my dear friends, degeneration of the atlantoaxial joint is the most common form of degeneration of the spine. And we must try to understand this. When there is degeneration of the atlantoaxial joint, most mobile joint, it is atlantoaxial instability and vertical spinal instability, vertical. So reduction in the joint space, you see reduction in the joint space, buckling of the posterior longitudinal ligament, osteophyte formation are not primary events. They are secondary events related to instability of the atlantoaxial joint, related to vertical spinal instability. So these are secondary events. These are not the problem. They are the solution. Do not ever try to remove these osteophytes and do not ever try to remove this ligament. The issue is atlantoaxial instability and the treatment is stabilization. Ossification in the apical ligament, osteophyte formation. These are not primary events. Do not try to remove this by decompression. Decompression is not the treatment. Stabilization is the treatment. And I have no hesitation to say that any decompression is a negative form of treatment. Retrodontoid pseudotumor formation. I have to tell you, my dear friends, I introduced this concept that retrodontoid pseudotumor is a secondary event to atlantoaxial instability, even when it is not demonstrated on dynamic images. Retrodontoid pseudotumor is like an osteophyte. There is no need to do decompression or removal of this osteophyte, which is secondary phenomenon. It is when it is secondary to atlantoaxial instability, you stabilize and it will disappear. So a retroodontoid mass is an evidence of craniovertebral junction instability. Do not remove this. You stabilize and you see the magic. You see the magic, absolute magic. And this, we introduced this concept that retroodontoid, there is no need for any kind of decompression, whether it is with microscope, whether it is with endoscope. What you need is atlantoaxial stabilization, and you see the magic. Retroodontoid cyst. If you read the articles in the literature, many people will come with endoscope or with microscope, with anterior approach, with lateral approach, and with various kinds of approach to remove this pseudo cyst. We are saying, and I have no hesitation to say, that this is not a primary event. It is secondary to atlantoaxial instability. You stabilize and the disc disappears. Even sometimes it can disappear in the immediate post-operative period. More importantly, it is not necessary. In my estimation, it is a negative operation to remove this cyst. This is another cyst with clear evidence of instability. You remove this cyst, it is a negative operation. This is a cushion. This is a bag. It protects the cord inflection and extension. Like Chiari malformation from behind, this is a cushion from front. You do fixation, it disappears. Do not remove this cushion. It will be absolutely negative for the patient. So we have several patients where we have done only fixation. Even this, there is no instability on dynamic imaging. You do fixation, it disappears. Another beautiful thing, you see in os odontoideum, there is a cushion here. And this cushion goes inside the bone. In dynamic images, you see there is a defect in the bone. There is a cushion and there is a defect. And this cushion is a secondary natural protective cushion. You do fixation and this cushion disappears. You do fix, you see this retroodontoid and pseudotumor in degenerative spine. There is a bone destruction here. There is a cushion. You do this fixation and this cushion disappears. So I discussed recently, and I wish you can read this article of mine where we have said that retroodontoid and retro C2 body cushions are beautiful, beautiful, divine cushions. They need to be understood, they need to be retained, and they need to be protected. Rheumatoid arthritis. Believe me, my friends, this pannus was considered to be a pathological event by the whole world, and transoral surgery developed to remove this pannus. So pannus was removed everywhere in the world till some drugs came into picture, and this pannus is no longer a very serious issue. You see, there is a possibility of immediate post-operative regression of this pannus after fixation. And this was published in Journal of Neurosurgery. I wish you can read this article. So we introduced this concept of fascital distraction and reduction of dislocation. This atlantoaxial joint jamming fascital distraction we introduced several years ago. Many people in the world are using this distraction. Now I go to the facets of subaxial spine. You see this bone. This is the most beautiful facet, the strongest bone of the whole vertebra. The body is very flimsy and thin. Pedicle is not so strong. Facets are the strongest. They are the weight-bearing issues of the body. The whole muscles from the spinous process, from everywhere, are dedicated or focused on the facets, which is the fulcrum of all movements. Fascital instability, like C1, C2 instability. No one in the world has really understood fascital instability. No one in the world. Fascital instability is the primary issue. Instability, vertical spinal instability is the primary issue. Disc space reduction is not primary. Multi-level disc bulges are due to vertical spinal instability. Osteophyte formation is not primary. The whole world wants to remove the osteophytes. The whole world wants to decompress. I am saying that the whole issue is instability. These are all secondary, these are all protective, and they will disappear after stabilization. This concept I am going to present to you. So vertical fascital instability is the nodal point of genesis of spinal spondylotic disease. So I will go from my historical perspective. I want to present what I used to do in 2010. So this article I wrote in 2010, where we said that the fascital listhesis or fascital space reduction is the issue. You introduce a spacer in the facet, and this bulge will disappear in the immediate postoperative period. This ligamentum flavum buckling will disappear in the immediate postoperative period, and there is no need for decompression. So this is what we introduced in 2010. So you see there is multi-level disc bulges, multi-level ligamentum flavum bulges. These are not primary events. They are secondary to vertical spinal instability. Don't go on removing all these segments. Don't go on removing all these segments. You have to stabilize. You have to stabilize. I stabilized in 2010, 11 years ago, using fascital distraction spacers, and they created magic. They created absolute magic. They introduced a new disc in the picture. They completely removed the osteophyte. They completely removed the ligamentum flavum, and most importantly, magically improved the clinical condition of the patient. So you can use multi-level fascital distractors for multi-segmental disease. So what we said, for the first time in spinal degeneration, that compression is not the issue, instability is the issue, and arthrodesis or stabilization is the treatment. Any form of decompression is a negative form of treatment. So we have got multiple cases like this where we have done fascital distraction and arthrodesis, and you see there is a new disc. You see the whole cord is completely decompressed, and you see the magical outcome of the patient. Unfortunately, my patients are talking in Indian language, and I cannot make them talk in any other language, so I cannot present you patient. So we have got several patients where I used to do. I'm not using it now. You see fascital distraction and arthrodesis and magical clinical outcome in the radiology. So there is multiple patients where we have achieved arthrodesis and there is no decompression. What I want to give you this message, a revolution, that compression is not the problem and decompression is not the treatment. Stabilization is the treatment. So you see multiple patients like this where we have treated, you see the whole structure has been completely arthrodesis. Basically, it is vertical spinal instability, which is the problem, and stabilization. You see new disc at each level and no compression, no anterior, no posterior. This is the treatment. So this intrafascital, intraarticular, it was a concept. It was a technique, all right, but a concept which is completely, the whole world was saying disc space reduction, disc water content reduction, disc space degeneration are the issue. The whole world is still talking about it. I am saying that disc issue or disc space reduction, osteophytes are not primary. They are secondary to one issue, which is your muscle weakness. You have not taken care of your body. Disuse, abuse, misuse, injury to your muscles lead to weakness of your muscles and vertical spinal instability. So we introduced this article in 2010 with a cover page illustration in Journal of Neurosurgery. I wish you read it. I wish you try to understand it. And I wish you use it. So this is a new hypothesis of spinal degeneration. So these are my spacers, and these are very heavily patented in various formats.
Excuse me, Atul.
Yeah.
With all due respect, we have 5 more minutes, okay? 'Cause a lot of people want to answer.
John, I will need at least 20 more minutes. And
okay.
I want Samay to, because I'm presenting an absolute revolution, John, 20 more minutes, I'm not going to stop. Okay, did you hear that? Samay, did you hear that?
The king has spoken.
The king has spoken and you listen to the king.
Okay.
Okay.
Go ahead.
Okay, I will be a little faster, John, with respect to your version. Okay. Now you see this immediate post-operative disc herniation. There is a disc herniation. The whole world will come and remove this disc. Is there any question in anybody's mind? But there is a potential of immediate post-operative regression of this disc by fascial distraction surgery. I don't want to go in details. The same concept we introduced for lumbar spine, introducing of intra-articular fascital spacers as a treatment for lumbar canal stenosis. And we published this in Journal of Neurosurgery. The concept is same, vertical spinal instability, vertical or telescoping of the spine, not compression. Decompression is not the treatment. So decompression or the compressed or deformed neural structure is the basis of the treatment for spinal degeneration. In the year 2013, we said that only fixation for cervical spondylosis is necessary. No need for even distraction. And in the year 2020, I presented my series with 215 cases where we did only fixation, no decompression for degenerative spine. You see here, there is the whole world will come to do 1 level or 2 level ACDFs, and you all agree that ACDF is the treatment, decompression is the treatment. I do only fixation, and I am saying this will reduce in 6 months. You see these osteophytes have disappeared spontaneously. More importantly, you will see a magic in the patient. Multi-level degeneration. Don't do any kind of laminoplasty. Don't do any kind of corpectomy. Don't remove this osteophyte. You stabilize, you achieve arthrodesis, and you see the whole thing will neutralize and normalize. There is no compression. This is after 1 year. More importantly, is immediate post-operative, this patient will remarkably, and mark my word, remarkably, mark my word, magically, he will improve in, you see this multiple, what you will do? You will do either from front or from behind. Decompression, I am saying decompression is not the issue. The issue is instability. You stabilize by this transarticular fixation, and you see the magic that you have never seen in spine surgery. So this is a new revolution in degenerative spinal surgery. Instability is the cause and stabilization is the treatment. It is not neural deformation or compression, but instability is the cause of symptoms in degenerative spine. More important is you have to understand which segments are unstable and which segments need to be stabilized. And this is not an easy issue. On the basis of clinical parameters, on the basis of radiological parameters, you have to identify. You see, this is 2 level, but I have done 4 level stabilization. And you see the whole system has normalized. Which segments have to be stabilized is a very important issue. Multi-level, do not do any kind of decompression. Only stabilization is the treatment. And I have got many 100 patients now. And I have, you see, you do fixation, and suppose it does not work, you can come from front and do decompression. But I am saying I have never required a second operation to do decompression. So these are multi-level issues and multi-level instability. Stabilization is the treatment. Decompression does not form the treatment. Another magical, Samay, I hope you are, don't talk of time with me, okay? John, please, just enjoy this magic. In spondylotic disease, there is also atlantoaxial instability, which is very commonly and frequently associated. You see, this is multi-level degeneration. There is central or atlantoaxial instability. There is no compression, but there is instability. You have to stabilize atlantoaxial joint and subaxial spine. When the patient presents with severe myelopathy, atlantoaxial instability is almost always present. Even if there is no fascital malalignment, you have to stabilize atlantoaxial joint if you want to see the magic. If you do not do atlantoaxial fixation, the patient may not improve to that extent. So we introduce an alternative method of fixation, which you will like to read from my paper, where we have done, you see this, there is no compression at this level, but I have done C2-3 fixation also. And you see this patient who was on a wheelchair is now walking beautifully. More importantly, I am saying, and that is the concept, that decompression is not the treatment. Decompression is a negative treatment. Stabilization is the treatment. And I have got multiple patients with this kind of issues. And I have got in the audience multiple followers of mine who are doing this kind of treatment. Don't think that this is an abstract form of treatment. In the audience, I know that there are many people who are doing for this kind of compression, no decompression. You see, there is no bone removal. There is only stabilization. And I can tell you magic. Same thing for lumbar canal stenosis. You see, this is in neurosurgical focus, analyzing the role of stabilization and futility of decompression. This is not it is in publication. So for this kind of lumbar canal stenosis, you do not do any decompression, you stabilize and you see the absolute magic. Whether you do with endoscope, whether you use with microscope, those are secondary issues. Those are technological issues or technical issues. This is an revolution in the philosophical understanding that lumbar canal stenosis needs only stabilization and not decompression. Stenosis, this word is wrong. We should not, when there is stenosis, it means you have to do decompression. It is not stenosis. We like to call it multi-segmental instability, and multi-segmental stabilization is the treatment. Is it necessary to remove the osteophytes in degenerative spine? The whole world is removing the osteophytes, and the entire surgery is based on removal of osteophytes. I'm saying, no, don't remove the osteophytes. This is my article you will like to remove. Read. These are osteophytes. You stabilize them, osteophytes will disappear spontaneously. And I have got multiple patients, like when I have done stabilization, the osteophytes have disappeared spontaneously. Is the term degenerative spinal canal stenosis is a misnomer? I'm saying absolutely yes. This kind of kyphosis or scoliosis or degenerative deformities are not primary. They are due to multi-segmental instability, and multi-segmental stabilization is the treatment. You please read this article of mine to go into details of how I do and what I do. Most important, I do not do any decompression. Another beautiful thing about herniated disc, I do not want to talk in 1 minute about this, but herniated disc is secondary to instability or causes instability. That is why collars are good and belts are good. You stabilize and the disc will disappear. Don't remove this from front. Don't remove it with endoscope. Don't remove it with microscope. You stabilize this segment and it will disappear spontaneously. You read this article for greater details. Similarly, for lumbar radiculopathy, you do not remove this disc. You identify the unstable spine. You see there is water in the fascial articulation. You stabilize and the disc will disappear after 6 months or 8 months, but the patient will instantly improve in the symptoms. And I'm absolutely convinced that this is, of course, quite many people will suddenly jump on me saying that, no, we don't agree. We will not like to do this, and this is not good, and this is not correct. But try to see, because this is the revolution. If you do not like it today, you will like it tomorrow. Believe me, I am telling you. Ossification of OPLL. This is another thing in spine surgery. Many of you know OPLL are the dangerous issues in spine surgery. Decompression is the only treatment which has been discussed. I described for the first time oblique corpectomy for these issues. And this is but now I am saying that atlantoaxial instability and subaxial instability is the cause of OPLL and stabilization is the treatment. OPLL, do not do decompression from front. Do not do any laminoplasty. You stabilize with very easy technique, this Camillus technique, and you see the magic. Only fixation for OPLL. This was the article I published about 10 years ago. And more recently, I published my experience with 52 cases. You please read this article to see that there is no need to remove this. There is, even when there is no demonstrable instability on dynamic images, atlantoaxial and subaxial fixation will introduce magic to your patient that you have never realized with OPLL. And I also say, if you have a doubt that this may not succeed, you have already stabilized, you can come and do decompression. I am telling you, I have never needed this second operation of decompression in OPLLs where I have done atlantoaxial and subaxial stabilization. Can it revolutionize cervical myelopathy treatment of OPLL? I'm saying absolutely yes. It will revolutionize the treatment of of OPLL. This Camillus technique is a very unused or misused or underused surgical technique. Such a wonderful technique. I have recently published my experience in Journal of Clinical Neuroscience. I sometimes introduce 2 screws, sometimes 3 screws. This is a wonderful, these are 3 screws you can introduce, and this is a solid fixation. Facets are the strongest bones, like for atlantoaxial joint. There is no bone as strong as the facet. This fixation is the strongest. The revolution is, can decompressive laminectomy for degenerative spondylotic lumbar and cervical stenosis become historical? Absolutely. Is instability the nodal point of pathogenesis of cervical degeneration, lumbar degeneration, and OPLL? Absolutely. So now I'm giving you another thing. Like I demolished transoral surgery, like I demolished foramen magnum decompression. Similarly, I want to demolish anterior cervical spinal surgery. All this decompression from front and decompressions from back, all this endoscopic decompression and microscopic decompression, from only decompression to only fixation can be the treatment. So can it revolutionize? Yes. So my final sentence is, compression is never primary. I'm not talking of tumors and all those things. Compression is never primary. Decompression is never the treatment. Thank you very much, my dear friends. Sorry for taking more time, but I know my dear audience will have enjoyed this beautiful new revolution in spine surgery. And this is not an ordinary revolution. This is an absolute revolution, my dear Samay. And I want you to give me a good smile. That smile has not come.
Thank you, Doctor.
Thank you.
Thank you, Sir, for this excellent presentation. You have raised a lot of questions in our minds and in chat too. But I'd like to ask you about this case that sent by one of our colleagues asking about what's your opinion. Is it clear?
My opinion is absolutely clear in this case. Absolutely clear. Do not do any laminectomy. Do not do any corpectomy. Do not do anterior surgery. You do multi-level Camillus technique from C2 to C6-7. You do a quick operation. This operation, posterior operation, I do in 15 minutes. You do not do any corpectomy, no laminectomy, no laminoplasty, and you see the magic. And you have to, when you do this operation, you tell me, yes, doctor, I have seen this magic and I thank you. You must tell me this. Okay?
I'd like to put some history about this patient. He is female patient, 6 years old, RTA, quadriplegic, paraplegic, C6 fissure fracture, and C7 fracture. You have the same opinion, or you will change it?
No, same opinion. I can see some C3-4 fusion here. I can see some problem in the C6-5-6 disc also. But I think if this patient has myelopathy symptoms, you must do posterior multisegmental stabilization.
Okay, yes, thank you, sir. And now, is there any question from panelists?
I am Dr. Salek from Bangladesh. I just want to know about the screw sizes in cervical spine and in the lumbar spine.
Yeah. Are you first, Dr. Salek? You tell me first. Do you think it is a magic? Say loudly, yes.
Yes, I'm enjoying this surgery in the spondylosis, then OPLL. Excellent. I'm doing it.
So you agree with my concept? You agree with my philosophy? Yes or no?
Yes, of course.
Thank
but
you.
it will take some time to come to a level. Thank you, sir.
Now the screws about cervical spine, I use 14 millimeter or sometimes 12 millimeter. For lumbar spine, I use 18 millimeters, sometimes 20 millimeters. And 2.7 to 2.8 millimeter thickness, not very thick, like not 3.5 or 3.6. My screws are relatively thinner. They are 2.7 or 2.8 millimeter thickness, 18 millimeter in length in lumbar spine, and 12 to 14 millimeter in cervical spine.
Okay, thank you, sir.
Excuse me. Thank you, Dr. Atul, for your this impressive presentation, your expertise, and the impressive number of operation in cervical, lumbar, or cranial cervical junction speak for themselves. And personally, I have no doubts about this indication. And I become one of your disciples.
Thank you. Thank you. Like John has become my disciple.
Thank
John.
you.
Well, I just request the king that I be beheaded and not shot.
Okay, John. Thank you very much, everybody.
Can I speak, Dr. Atul?
Dr. Omar, you will ask your question.
Okay. Thank you, Professor Atul. Very, very nice and magic. And I agree with you for this this atlanto-axial stability, and also for lumbar and for the cervical. I ask for the thoracic spine also the same times, the same philosophy, Dr. Atul.
Thoracic spine, also the same philosophy. Thoracic spine, I have got, I have not written anything about thoracic spine up till now, but my concept is the same. I have got several cases, but because I have not written about it, I have not presented. Now, I must also tell you that whatever I presented now are very heavily published in various journals in the world. And those who have some confusion and those who have some doubts and all, they are all in publication in top journals of spine, like Journal of Neurosurgery, Spine, and various other journals. And I wish that, you can go through. As regard your question, I cannot talk about thoracic spine at this time.
Okay, thank you very much for you. But we agree with you for this philosophy of the liberation of the spine surgery.
Thank you.
From neck to the sacral. Thank you very much for you.
Okay, yes, thank you, sir. There is a lot of questions in question box and in chat too. We will take just one more question from panelists. Any question?
One question is there, Samay, on this about the follow-up and all. One question on the chat box. And I have to tell you, and you have to just, either you believe me when I talk. And if you don't believe, you have to come and visit me. There are only two options. Or you say, I don't believe you. That is the third and last option. One is you believe what I'm saying. Second is you come and see what I'm saying. Third is you say, I don't believe. Now what I'm saying, you believe. That when you do a good fixation to the defined levels, your clinical improvement will be magical in the evening of operation. That you have never seen with anterior surgery, with corpectomy, with laminoplasty, that you have never seen. I was doing these surgeries myself for several years. But this Camille's technique, this fixation is absolute, absolute.
I have one question.
Yes, of course, my dear friend.
Doctor,
yes.
We have a good option for the decompression, for the stabilization, the fixation. We had to make a great sacrifice of posterior ligament complex and the muscle, and the patient that will have will lose the range of motion after the fixation. What do you think about this?
So, Dr. Lim, first thing I tell you, Dr. Lim, that
Yes.
I respect your work and I follow your work, and you are one of the very big masters of endoscopic surgery, no question about it. So I am not trying to argue your work. You are a very big man in your field. As far as this is concerned, I am absolutely convinced that decompression is not necessary. It should not be done. When the segment is unstable, and you find an osteophyte, you find a ligamentous buckling, you find a bone formation, you find OPLL. If it is unstable, you remove the bones. My feeling is, and I'm not just talking, I am talking on the basis of a very big experience, that when you remove the bone, when you do decompressions, you might get some immediate relief. Like you give painkillers for infection, you get some relief. When you give decongestant for some throat, for you also have throat infection at this time, you take some decongestion, you will improve. But what you need is not decongestion. What you need is antibiotics. You need to control your infection of your throat, then your voice will come back. You take decongestion, it will improve for some time, but essentially you are harming your throat. You agree, Dr. Lim? Yes. So basically, when there is an osteophyte, it is a natural response to instability. You remove that osteophyte, it may be all right for some time, but that pain, that lurking pain may continue for a long period of time, and ultimately it will harm. On the other hand, use your endoscope to stabilize. And because you are a master of endoscope, you use your endoscope to stabilize with minimal exposure, and you do few cases and you see for yourself what kind of results you're getting. So I'm saying that decompression, I know you are doing decompression. I know that the whole world is doing decompression. But this is what I think is a revolution in the understanding of spine surgery. You please, Dr. Lim, you are a senior endoscope surgeon and a senior spine surgeon. You please try this. And if you get good results, you please report to me. And you use endoscope for fixation.
Okay, I will catch you.
Okay, thank you.
Thank you.
Thank you, Sir, for this excellent presentation. There is a lot of questions in chat box. Please try to answer it as possible. And now we will shift to next speaker, Professor Mohammed Zilili. Please start sharing your screen.
Hi, everybody. It's my pleasure to be with you on this very nice symposia on spine surgeons. Thank Atul for presenting us very interesting results. My talk will be dealing with a very popular subject, dynamic fixation or mobility preserving surgeries. Is it a fact or fiction? Yeah, because sometimes some new concepts are introduced, but then they fade by the time. And then the real indications and contraindications are set up. Yes. This is my presentation order. Is there a problem with dynamic fixation? What are the type of mobility preserving surgeries? Aim of the mobility preserving surgeries? Evidence in the literature and conclusions. Is there a problem? To me, there is a real problem because those mobility preserving surgeries claim that fusion surgery, which is classic for many years, must be changed. And mobility preserving surgeries need new implants and approaches, some of which have more risks and complications. And they are expensive, and the company campaigns and supports shadow the real results of those surgeries. If you look at the PubMed search, this is a very recent search, you can find almost 20,000 hits for lumbar fusion, similar amounts, 18,000 lumbar fusion surgery and spine fusion. However, for arthroplasty, disc replacement, lumbar artificial discs, the numbers are very, very small. So then our information is not big with mobility preserving surgeries. So what are the types of mobility preserving surgeries? There are many types actually. One is the total disc replacement. Another one is the nucleus replacement, interspinous distractors, posterior dynamic instruments, and facet replacement devices. Total disc replacements has been popular in cervical spine, especially in cervical spine. Nucleus replacements have been unsuccessful, and they are no more in the market. Interspinous distractors are still popular, but they are not much used as it is before. Facet replacement is not approved by the FDA and still experimental, and probably posterior dynamic instruments are on the market. There are many types. Cervical arthroplasty is easy and popular. However, lumbar arthroplasty has started before cervical, and since it needs a major anterior surgery, it has lost its popularity. So indications are not clear, and there are problems with cost-efficacy ratio. I don't know if all the young surgeons remember those devices, PDN, prosthetic disc nucleus, or there were nucleus implants, nucleus and others. However, they faded by the time. Randomized controlled multicenter studies were lacking. Implant movement were still a major problem, and because of implant movement, reoperation rates has reached up to 20 to 30%. PDN, prosthetic disc nucleus, and NUBAC device have been removed from the market. There is no more. What about interspinous distractors? There were many types, and some types were be able to be placed by a minimally invasive technique, even under local anesthesia. What were they trying to do? Since canal narrows during extension or walking, interspinous distractors are widening the canal, and they could be effective in moderate spinal stenosis patients. However, their current popularity is not like before. What about posterior dynamic instruments? Probably the first types were from Dynesis or Isolog, the companies are those. They had basically they had two types: ligament-based systems or screw-rod-based systems. The graph, dynesis, and fast systems were real dynamic stabilization. After placing pedicle screws, you were connecting the screw heads with some ligaments. So they were not torn out during flexion extension. They were partially restricting the flexion, especially, and not restricting rotational movements. However, screw rod systems are restricting more rotational movements and allowing less flexion extension. These are some examples of ligament-based systems, and these are some examples of rod-based systems. Facet replacement, one was TOP system, total facet arthroplasty, removing all the facet and as for posterior elements, and then placing something like a amortizing implant on the back of the spine. If you look at the current condition, total disc prosthesis, especially for cervical spine, is in clinical usage. Posterior dynamic stabilization is also in clinical usage. Interspinous distractors are fading. Prosthetic disc nucleus facet replacement are not on the market, and the annulus replacement and repairs and some others are experimental. The companies are still trying to implement them in the clinical usage. This graph is from a company report which was claiming that the severity of treatment will be changed by the time, and those fusion cases will be replaced by total disc replacement or some mobility preserving surgeries. They wish this. What is the aim of mobility preservation? If you look at the aim, the main reason is that the adjacent segment disease. They claim that those surgeries will diminish adjacent segment disease. And another claim is that fusion surgery has more complications, and those surgeries create less complications. So then the other questions arise. Do those surgeries really prevent adjacent segment disease? Do hydroxyapatite coated screws really prevent metal fatigue? Because they had some analogy with the other joint arthroplasties, like hip arthroplasty or knee arthroplasty. But the spine is not a real joint like hip or knee. Why they prevent rotation, not flexion extension? Why dynamic implant, very heterogeneous groups? And what are the indications? Actually, disc herniation, listhesis, deformity, one level, multiple levels, and do we have high-level studies and high-level evidence? So the critics are timing, indications, complications, cost-effectiveness ratio, and high-level evidence studies. If you look at that phases of Kirkcaldy and Willis about the disc degenerative diseases, there is dysfunctional phase, instability phase, and stabilization phase. And those mobility preserving surgeries are against the natural process of the degeneration, because mostly they end with a stabilization phase or a fusion. So fusion surgery correlates to natural process. However, dynamic fixation is against the natural process. Is it possible? What is the timing? If the dynamic implants in long term, if they result with fusion, it's an expensive and useless technique. If no fusion, it's a biomechanical disadvantage. Actually, we know, especially in cervical arthroplasty, the heterotopic ossification, the body tries to fuse that level, although you place a mobilization at that level. So the stepwise treatment, which was tried to be suggested to us by the companies, the compassion, mobility preserving, and then fusion, is not working for the natural process. This study, which is a systematic literature review, looking for the dynamic or hybrid lumbar spine stabilizations, says that they can have advantages in certain indications. However, those are the cases with moderate degeneration and new onset instability. Still higher quality studies are necessary. So then it doesn't conclude with that dynamic fixation is very useful. And probably according to that concept, we can have cases of lumbar degenerative diseases making just spinal fusion, or a part of it may turn to mobility preserving surgeries. What are the complications of mobility preserving? As I mentioned before, heterotopic ossification is one of them. The body itself defenses against preserving the mobility. Screw loosening and breakage. Although you use hydroxyapatite coated screws, doesn't matter, it may happen. Compression, dislocation, wear debris, and osteolysis are some other complications of those. And at the end, although you place a dynamic fixation, with the heterotopic ossification, a fusion may happen. In this study, 126 patients, 19.8% of the screws have loosened in 25 patients. This is one example of my observations. This is one of my cases. She had a young female patient. She had a L5S1 dynamic fixation, axial pain since 2009, and on the direct radiographs you can see easily a halo on the S1 screws. Yes, although one of the screws is not properly placed, it is on the ela, not going to the promontorium, but screw loosening is here. What did I suggest? First, injections. If they don't get any benefit, then fusion surgery may be offered. What about this case? 71 years old male, 2-level dynamic fixation, leg pain resolved. However, he came back 2 months later with back pain. And you can see an adjacent level disease at this patient. So, although they claim that adjacent level disease will be prevented, it has happened with 2 levels. So, critics. Failure of fixation without fusion is well known for many years. We must never forget the fact that those patients get more pain 3 to 6 months later. And should we consider all fixations without fusion as dynamic fixation? Actually, nowadays, since fixation devices are very popular, we see more and more non-union patients, and we revise them. And The same can happen with the dynamic fixations. What about the evidence in the literature? This is more important than anything else, probably. This study is saying that instrumental levels carry the loss. This is not true for dynesis and rigid fixation. This is same. Instrumental levels carry the loss. This study from 2007, dynamic implant does not necessarily reduce axial spinal loss compared to an uninstrumented spine. They allow some controlled movement. Yeah, they can, but problem is how will the surgeon decide? What is the optimal range of motion permitted, best fitting for individual patient, and how will he or she choose which implant is the best? This is still not validated, even by biomechanical studies. They reduce the degeneration in the adjacent segments. As I have shown the example, it's not true. Incidence in cervical spine is about 3%. Incidence in lumbar spine 2 to 14% adjacent segment disease. Are we talking about 3% incidence to lower this number with new implants and very costly, expensive implants? It's interesting. Yeah. Another thing is that adjacent segment disease is the etiology is multifactorial, and there are various reasons other than fusion of the motion segment: injury to the posterior ligament complex, sagittal imbalance, lacking awareness of the lordosis of the lumbar spine or cervical spine. Such things may also cause adjacent segment disease. There are studies that for cervical arthroplasty, for instance, these are studies from 2012 and others, which is telling that the arthroplasty reduces adjacent segment degeneration. However, this meta-analysis from 2012 is saying that with current evidence, we cannot conclude that cervical disc arthroplasty significantly reduces the post-operative adjacent segment disease. There are some studies, yes or no, like this study from 2012. Not all the studies are blinded, saying 8 out of 9 studies are company supported and maximum 1 to 2 years results. Actually, these authors have telling that all those cervical arthroplasty IDE studies have been done by persons who already use cervical arthroplasty in their practice, and that they like it. So there are still bias for using them. Do they? This is again no, saying for lumbar spine, dynesis could provide sufficient stabilization in degenerative instability. However, movement in adjacent segment is not different than rigid fixation. And these two studies are graft ligament is not successful. In Vaccaro's paper, which is trying to summarize those in 2009 to draw some conclusion that a posterior dynamic device is better than fusion, results from multiple similarly designed independently funded trials. Independently funded trials must be compiled, compared, and contrasted. This 2015 systematic literature, very large series, and there are 4 studies from my country with Dr. Fahir Özer and his group. Actually, they are telling that it has no apparent difference in prevention of adjacent segment disease. and dynamic stabilization can have advantages in selected indications. Those are medium level degeneration and new onset instability. They should not be used in very elderly patients. Another one, dynamic fixation with Coflex, 2018. Coflex treatment can reduce the influence on adjacent segments and delay degeneration, but that is all. Let's skip some of them. And this is with interspinous device, DIAM and interspinous U, 5 years follow-up, and saying that this reoperation due to severe back pain is about 16% in interspinous U, with the DIAM 28%, very high level. The new concept is that topping of implants. Actually, you can use rigid fixation with fusion for some levels, but for the other level, mostly upper level, to prevent adjacent level disease, a top of implant with mobility preserving device like this, dilated screw, transition screw. So-called hybrid fixation, ASD incidence is 4.76%. So there's another topping of implants paper, 22 patients. ASD of the segment cranial to the topping off is 3 cases, lower. So it has gathered more popularity recently. Yeah. Yes, this is with 3 groups, with topping off using dynamic screws, topping off using interspinous process devices. So this is another study. At the index level, the effect of hybrid stabilization device or interspinous process device for decreasing ASD have been found similar. Again, another topping of implant paper. This 22 recent paper, in current conditions, we cannot conclude that Dynasis dynamic stability is superior to fusion surgery in lumbar degenerative disease. So, if you look at the evolution of them, first devices were ligament-based, then rod-based, semi-rigid dynamic fixation, then peak rods have been used, but there have been some breakage of the peak rods, so they are not as popular as before. So the recent trend is a hybrid fixation and topping of implants. So as the WFNS Spine Committee, we recommended that mobility preserving surgeries is not the only way to prevent adjacent segment disease. And we said that decompensation is the basis of surgical treatment for lumbar spine stenosis, and adjacent segment incidence can be decreased by applying other measures, not just mobility preservation. In conclusion, for lumbar spine stenosis, still not a role. Is there a role of dynamic fixation? Outcomes are similar, benefits are not as presumed. New shift to hybrid fixations or topping of devices should further be evaluated. Do dynamic fixation implants prevent adjacent? Yes, they may prevent adjacent segment disease, but if it is really necessary, long-term and multi-center controlled trials are necessary to really believe that concept. And fusion is still a gold standard in lumbar degenerative diseases. Among well-selected patients, it gives effective and continuous results. Fusion surgery has 2 main critics. One is the non-union pseudotumors and adjacent segment disease. However, mobility preserving surgeries can have wide application. Although they can have wide application, there are many techniques. Evidence-based medicine does not support them very well. There is still a big lack of level 1 and level 2 studies. And the most studies are done by surgeons who use those implants. And the main objective, it reduces adjacent segment disease, has not proven yet. They are expensive devices. To prevent adjacent segment disease, we can apply minimally invasive surgeries. We can apply protection of muscles and ligaments. We must use short segment fixations instead of longer segments, preserve lordosis, and SVA must be less than 50 millimeters. Answers for timing, as I mentioned before. Indications not clear, it must be in the early phase of instability. Complications, in contrast to their claim, they have more complications, especially screw breakage and loosening. Cost-effective ratio is worse, more expensive. Okay. And in general practice, many cases operated for fusion, but without trying placing a good fusion bed and placing good enough grafts. They can also be considered as dynamic fixation, and their results are not good, and they commonly need a revision surgery. This is probably the indications, although they were telling such a large indication at the beginning, probably their indications must be confined to that smaller area. Thank you for listening to me.
Thank you, dear friend, for this excellent and illustrative lecture. Is there any question from panelists?
Hi, good morning, and greetings from Canada, and lovely to see all of you, albeit virtually. Mehmet, thank you for that very thoughtful lecture. So, do you think that there's any potential role in the cervical spine to top off, say, an anterior cervical fusion with an arthroplasty? Say if you have, say, a 2-level ACDF, but the 3rd level is a bit questionable. So sometimes it's a question, you incorporate in the fusion or not. And I had wondered whether maybe an arthroplasty in that setting might make sense, but I'd be interested in your thoughts.
Yeah, this is also one of the trials some cervical spine surgeons are doing. Actually, I don't think a 3-level arthroplasty or 3-level ACDF is a good option. Yes, you are right. It can be applicable to cervical spine as well, not just lumbar spine, top-off systems or hybrid systems. Thank you, Michael.
Thank you, Sam. Is there any question? Thank you, Professor Zilili, for this excellent presentation. And now we will shift to next speaker, Professor Onur Yemen. Please start sharing your screen. Thank you, sir.
First of all, I'd like to thank to Samih for this kind invitation. So I'll talk about a new concept in spinal deformity corrections. First of all, in the past, it was difficult to operate these kind of spinal deformities. Nowadays, they're still difficult, but there are some things that we can do to make it much easier. So, start from the pediatric cases. The specialty of these cases are that you have to try to prevent the progression of the curve, but also you have to let the spine to grow. So if you fuse these pediatric cases in very young ages, you may prevent the progression of the curve, but at the same time, you reduce the thoracic volume and you decrease it. So it eliminates the growth potential. And also the early fusion decreases the force vital capacity. So there are techniques that we can use as the growth-friendly techniques. So there are lots of growth-friendly techniques. I'd like to talk about the growing growth technique. So in this type, you apply a growing growth. It can be a mechanical or it can be a magnetic control growing growth. So you need an X-rays to determine the instrumented levels. So this is a case that we have applied a growing growth, and this is the device. And the thing that you're doing, the idea is first you do the first surgery, then in every 6 months or in every year, you follow up the patient, and in the operation, in the outpatient clinic, you can increase the length of the rope there. So the only thing that you have to do with the helping of this device, you distract the length of the rod here. So you find the rod's place, and the only thing that you have to touch the device, and you increase the length of the rod here. So another thing that we're doing nowadays is the hollow traction gravity. So this is the post-operative, the first day of the patient. So you see it's working now. The patient tries to use it. So in which cases we use it? Especially in the patients that we need to increase the volume of the thorax, we use it. So we do it with the local anesthesia. At the beginning, in the first day, we started at the 10% of the patient's weight. Then we increase it step by step. The aim of the traction has to be 50% of the patient's weight, and we apply it for 1 or 2 months. So the patient is using it while the patient is lying, sitting, and also standing. And in a few days, you see the patient adapts the device very easily. They use it for 24 hours. So does it work? It really works. This is the measurement of the patients before the traction, and these are the measurements of that patient after hollow traction. It increases the vital force capacity, and in some cases, which is not possible to operate, after using the hollow devices, you can get this patient in the operation. And also in the literature, it says that with hollow traction, you can reduce 10% of the scoliosis curve. Another thing that we're applying in these patients, I showed this case at the beginning of my presentation. While you're tracking these patients, also you get these patients to the physiotherapy. And if you get more muscles, you will have less problems of the head of the screws after the surgery. So with hollow traction on physiotherapy and the increase of the volume of the muscles, you can operate the patients, and this is after the operation. Another thing you may have during the surgery, especially in the congenital cases, especially patients over than 20-25 years old, you may have lots of cardiac problems, even you have it in the very young ages. This case was a congenital case, 25 years old. So in this case, when we get this patient in the prone position, we get a bradycardia. So we had, before the surgery, we had cardiology consultation, we got the echogram, but we had that problem. Again, we had consultations again. Then in the second, at the beginning of the surgery, when you change the position of the patient to the prone position, you get bradycardia. And in the second beginning of the surgery, we had a cardiac arrest. So at the third, so we tried to use a pacemaker during the surgery, and we could finish the surgery, started the surgery, and after finish the surgery. So using a pacemaker during the surgery will be fine, especially if you have a problem in the congenital cases. So there are also some, not revolutions, but some tricks and tips to operate the adult degenerative cases. This is a adult degenerative scoliosis and also kyphotic patient before and after the surgery. So what can we do in this type of cases? This is an ankylosing spondylitis case, another case. So we're having some measurements also in the sagittal plane. I use SurgiMap. So it allows you to plan your surgeries before the surgeries. So in a case like this one, you get the sagittal parameters before the surgery. This kind of software helps you to plan before the surgery. In this case, the patient has a severe sagittal imbalance. So you get the idea. Let's say we try to, if you do a type 3 osteotomy at L4 level, what kind of a sagittal balance that you're going to have, you can measure it before the surgery. So this type of surgery at this level will be not enough for that patient. So adding a type 2 osteotomy, I mean a Ponti osteotomy, will be again not enough. So we skip to corner osteotomy at L4, and we have added 2 levels Ponti osteotomy. So if you look in these measurements, we know that these type of osteotomies will provide a good sagittal balance. So another advantage of these softwares, you can also measure the length of the rod here and also the shape of the rod here. So according to the literature, let's show this figure here. If a patient is older than 74 years old, the difference between pelvic incidence and lumbar lordosis, if it's 17 degrees, it will be enough for you. So we measured it here. The pelvic incidence was 57 degrees and lumbar lordosis was 39 degrees. So if we get a difference between pelvic incidence and lumbar lordosis, let's say 17 or 18 degrees, it will be so if I can get a lumbar lordosis, 40 degrees lumbar lordosis after the surgery, it will be fine for me. So you can measure also the length of the rod here. So this is the shape of the rod. So I know that the lumbar lordosis and the length of the screw before the surgery. So this is a custom made, a pre-bending rod here. So we bended it before the surgery. It gives you the advantage to not spend time during the surgery. And also, if you can put easily this rod during your surgery, it means you have the proper shape. So you have to bring the spine to the rod without using any forces. So this is the intraoperative view of that patient. So this is the two separated parts of the C-arm. We get an upper part of the lumbar area and also the sacrum here. So I know.
That's nice. That's good.
Sorry. So if you get a 39 degrees lumbar lordosis, now so I know that this lumbar lordosis will be fine after the surgery. So this was before the surgery. This was my planning, and this is my after the surgery. So these are the clinical photographs of that patient, preoperative and postoperative. Another case, again, a lumbar degenerative scoliosis, adult degenerative scoliosis case, back pain and bilateral leg pain. Again, in this case, we can measure the sagittal parameters so that we can make a good plan before the surgery, which type of osteotomies that we need and at which level and which type of osteotomy. So it is decided to make an corner osteotomy. We call it as type 4 osteotomy. They measured it before the surgery, so they applied it. So these are the clinical and radiological X-rays of the patients before and after the surgery. So we achieved a good sagittal balance here. Another case with, again, elderly age patients had a previous lumbar disc surgeries and instrumentation. The patient has not a good sagittal vertical axe because the patient was using a pelvic tilt. So the patient tries to compensate it. So we again used pre-bending custom-made rods here. These are the intraoperative views. In these kind of surgeries, we use a T-shaped rod here to maintain the coronal balance here. So these are the parts that we get AP views of the C-arm. We combine it during the surgery and we see if we have a good coronal balance or not. So L3 and L4 are parallel to the floor before and after the surgeries, patients, X-rays and clinical photographs. So another thing that we can use during the surgery is kickstand rod technique. We use this technique to maintain especially the coronal balance. So if you look only at the lateral view, the patient has a good sagittal balance, but if you have a severe coronal imbalance, like in this case, this was my first case that I have used coronal imbalance, kickstand rod technique. I applied this technique wrongly. So what I have done, I changed only the position of the screw here to increase the forces, the distraction forces here. So this was before the surgery, after the surgery and revision surgery. So this is the technique. You put an extra iliac wing screw here, then you put an extra rod on the coronal imbalance side, then you put a strongly rod holder, then you distract it. So this is the technique that we apply during the surgery. So this was the case, my first case that I revised it here. So make it short here. So we change the direction of the screw here. Then we put an extra rod here. Then you fix the head of the screw that you have inserted it into the iliac wing here. Then you put your extra rod here. You connected the extra rod with the helping of a domino here. You fix it. At the same time, you lose the head of the screws here. And with the help of a strong rod holder, the only thing that you have to do is to distract that rod, and it helps you to maintain the coronal balance here. So this was after the surgery. Disadvantage of this technique, if you look on the sagittal plane with this distracting forces, you maintain the coronal balance, but with this distracting forces, you see you lose some sagittal balance here. So you are increasing the sagittal vertical axis here. So to prevent this disadvantage, let's say you have applied a kickstand rod on the left side. You balance the spine, but you lose on the sagittal plane. Then you have to put UCAN at an extra rod on the other side. And if you use a compressor, you can bring the spine back. And this technique is known as CAIRO technique. So after the first case, we started to use double rods, kickstand combined with CAIRO technique to maintain the corneal balance here and also the sagittal balance. So these are another cases, intraoperative views here. So another thing that we have now, in the past we didn't have it. Now we can use augment also the navigation systems in rotated spine or in very severe spinal deformity cases. So it really helps you to see the pedicle directions in coronal, sagittal, and also in the axial plane. If you have the chance to use it, it's very useful and it helps you, and also it decreases your stress during the surgery. So there are lots of things to talk about, let's say, revolutions in spine surgery, but I think in the future, custom-made devices will be used more common. Especially minimally invasive deformity surgeries will be very popular. Dynamic systems will be, I think, will be more common, and I think the technology will be more helpful in our surgeries. Thank you so much for your interest.
Thank you, dear friend, for this excellent presentation and these tricks and tips for this kind of surgery. Is there any question from panelists? Thanks again, dear friend, for this excellent presentation.
Thank you so much, Sami.
Now we will shift to next. Thank you, sir. And now we will shift to next speaker, Professor Shen. Please start sharing your screen. Thank you.
Okay, hi everyone. Thanks for having me. It's great to see everybody, and I'd like to thank everyone for inviting me to this webinar. One day, hopefully, we'll all get together in person. But today, I think this is really applicable. Following up on that excellent talk, I'm going to share with you a little bit about augmented reality and how I've been integrating this into complex spine surgery here in Boston at the Mass General. So as everyone knows, we're seeing a lot of navigation now in spine surgery, whether you're dealing with degenerative disease, deformity, or oncology. And I think if you go to any meeting or you're just looking at the journals, looking online, you're going to see a lot of different systems now with enabling technology, whether it's robot-assisted navigation, augmented virtual reality. There's sort of been this explosion of technology. And with this comes some advantages in operative planning, execution, and accuracy. And I think all of us recognize that almost every month in any spine journal, you're going to see some type of systematic review or some type of review looking at, efficacy, safety for these different imaging platforms. And, I'm very interested in this because ultimately, depending on what kind of case you're doing, I think we're all faced with improving patient safety and minimizing complications in general. And especially if there are things dealing with instrumentation, I think that it's good to be open-minded and think about how to incorporate some of these technologies. But where I'm very interested in is beyond the screws. So I think a lot of us can place the screws with techniques that you're used to, but I'm very interested in what about beyond that? Are there applications beyond screw placement where augmented reality can help us? And hopefully I'll be able to show that through some case examples in this presentation. I think everyone here is very well familiar with a number of these different platforms and imaging systems, whether you're using the O-arm and stealth navigation to Excelsius and Medtronic, Nuvasive. All these companies have various platforms. And again, there's a lot of literature looking at this, and I'm sure most surgeons have some bias and also with regards to what technique and technology they like to use. And sometimes this is also limited by the resources at your hospital, wherever you are in the world, and some of the constraints related to that. That's a practical aspect that we don't talk about a lot, but that is very much a reality for many surgeons in the hospitals that they work in. And this is just a picture of what my operating room looks like at the MGH in Boston. And you can see this is during a deformity case, and you can see overall, pretty typical, I think, what most would see in their operating room, right? You see cell saver on one side, or instrumentation. Here we have the stealth navigation tower and the camera, everything that we're used to. And, within a limited operating room for square footage, each of these instrument trays and all this different technology takes up space. And I think this is what most people are used to. So why is this important? Well, I think, when we think about navigation or fluoroscopic guidance or robotics, one of the things where we know that we can control is the placement of the instrumentation. In a lot of these complex cases, or even fairly straightforward degenerative cases, placing the instrumentation is one part of the operation, but it's a critical part because, as you can see here, misplacement of screws, they do have implications, whether it's lateral to the pedicle, along the vertebral body wall, if there was misguidance or for some reason that screw goes into the canal, or, the thoracic spine, these screws can get dangerously close to great vessels. And I think that, as spine surgeons, we focus a lot about advanced techniques, and just like in the last case and the cases before, MIS, open deformity, rod derotation, compression distraction, correction deformity. But in order to do that, it relies on placing the instrumentation. And so I think as the first step, I think being self-critical and thinking about how we can improve accuracy is always important. Now, my own bias here is that I do prefer freehand technique. That I did train that way. And for the most part, that's what I utilize from skull base to sacrum and pelvis, utilizing anatomic landmarks, visualization, and freehand technique. But there are limitations to that, admittedly. I think that in cases of revision surgery, cases of deformity where maybe, there is a solid fusion mass in areas that you need to break through, the anatomic visualization can be difficult. And I think that everyone here is very well familiar with various freehand techniques. And so, for various revision cases and for deformity cases, oncology cases, I do use standard navigation. But with the advent of augmented reality, I was very curious, but also, really trying to figure out if this is something that I could use that would be beneficial in ways that maybe is different and maybe better than conventional navigation. And I'm going to show examples of that. And the reason why is I think everyone is familiar with this. This is obviously taken from Marvel Studios, and this is Tony Stark and Iron Man. And I think that, I think this is a great visual because I think that the day of where what we do as surgeons in the operating room, it's not science fiction anymore. We're using a lot of technology. And it just seems that since the introduction of navigation, what's the next iteration? What's the next phase? And, just as like we utilize navigation when we drive, when we're planning trips, now we're seeing heads-up displays in various cars, so you don't have to take your eyes off the road. And similarly, what if we can bring the navigation and the pertinent anatomy and the guidance that we're obtaining with intraoperative imaging into our visual field, so that, when we're passing instruments repeatedly, across the field, around the nerve roots, the spinal cord, vascular structures. Can we optimize that? Can we make that safer in ways where we don't have to take our eyes out of the field, not only from the surgeon standpoint, but also from a training standpoint? You know, there is some advantage. And so that's what got me very, very interested in this. And I'm going to show you examples of how we started implementing that. So here's a case of a patient who had a previous fusion, multiple levels, and developed severe PJK, proximal junctional kyphosis and failure, with severe angular kyphosis, difficulty standing up. And I don't have the measurements here, but you can grossly see here that the sagittal, gross sagittal SVA is very abnormal. There's a focal kyphosis above this construct at the thoracolumbar junction, and you can see the changes there. And on the axial sections, you can also see how there is misplacement of the screws. There's also some haloing around the screws. And so the challenges here, you know, this patient, we're going to go revise this with multi-level posterior column osteotomies, you know, T10 to pelvis. And it's a complex enough operation. And is there a role for augmented reality? Well, you know, we train our residents. This is simulation here, and this is with the augmented reality platform. This is the Augmetic system, and you can see this is one of our chief residents wearing the headset here and practicing on a model. We did this extensively before our first case. And intra-op, this is an example of what we're seeing here. So the patient is prone, and this is a straight midline posterior incision. And like with most navigation systems, the exposure's been done. You can see the deep retractors are placed. And the cranial side is the right side of the screen, and caudal is to the left. And because of the number of levels that we're going to instrument, and again, we're going to take out screws, place new screws. You know, we place a spinous process tracker on a spinous process in the superior aspect of the field, as well as a pin into the iliac crest for the distal fixation. And what you see here it's basically the registration components for this platform. And that's represented here by the sort of off-white tabs that are locked into the navigation anchors. And again, this is our sort of view of the operating room here. You can see the O-arm coming in over the table, our implants, and the overall sort of schematic of what that looks like in the operating room. Here's another view. You can see here, this is a tower, and it's basically just a screen so that other people in the room can see what it is that we're seeing. Right now, the limitation of the system is that the augmented reality version of what I'm looking at or what the trainee is looking at, that doesn't get broadcast anywhere. But at least on this monitor, like a conventional navigation monitor, you can see what's going on. But as you can see at the foot of the bed, you know, there's not a tower, there's not a camera. And I think as many of us here know that in a lot of these cases, there's a lot of artifacts sometimes that slows down the case where you're trying to get the tower to see the instruments. And so that's one benefit here. So in terms of setup time. So our workflow is typically, we do the exposure, we'll put the clamps on, then we'll bring in the O-arm, get the spin, I'll scrub out, my resident scrubs out, as you can see here. We are putting on the headset. And another limitation here is that if you like to operate using loops, currently this does not allow to wear loops just because of the way that the headset sits over your eyes. But then once that's done, we do the CT scan, send that to the computer, and basically play around with the images here to make sure that we have adequate imaging, as you can see here, windowing it. So we know that we have enough to base our navigation on. And here, just like with any navigation system, we're placing the actual navigation reference dock onto the spinous process array. You can see the iliac crest based pin. This has a multifocal joint so that it can be oriented so it's not in the direction of where we're going to pass instruments. And we can use pretty much any instrument and register that instrument for navigation here with augmented reality. This is me here. You see the headset. You see there's no tower, or there's no There's no base stand for the navigation at the foot of the table. And here, this is the awl that we're navigating. And here, this is a power drill with a pedicle screw that we're navigating as well, getting close to place that instrumentation. And this is my trainee, Ian Connolly, who you can see here, he's placing the pedicle screw under direct visualization. So he's always keeping his eyes directly in the field and not getting distracted looking at another screen here. And I'm doing the same thing here, even for placing S2AI, iliac screws. It's very helpful because I know what the landmarks are, obviously, because we typically do this freehand, but it's a good way we can see the axial and the sagittal images. I'm going to show you that very shortly of what it is I'm actually looking at. So this is an example of what the screen shows. And here you can see that on the right side, here I'm revising a screw and there's a halo around one of the tracks. And because of the size of the halo, I wanted to try to navigate a new trajectory. And this can be difficult using freehand technique. And so we use that. You can see that being able to get right down into that area, avoiding the canal, avoiding the foramen, and that previous screw track. And here's just another example, similar to like the last talk, showing that we've already selected trajectory, as you can see here, and then getting the navigated screw, finding the trajectory, and then going for it. And you can see here the shadow of it. You can see myself and my resident. We're just like without navigation, eyes and hands over the field, not getting distracted by anything, and matching our placement with the planned trajectory. And just another example here. This is now placing iliac fixation. And again, we're used to doing this freehand. And even with navigation, we published a technique on using navigation for this when I was a fellow at the Cleveland Clinic, but here using augmented reality. And you can see I'm looking, I've identified the landmark, prepped it out, exposed everything, but using this to place the screws once I have that mapped out. And now this is giving you an idea, an example of what it is that I'm looking at. So on the right side, this is literally a sort of a camera shot taken with my iPhone that I had someone do right beneath the lens of my right eye. And you can see the outline of the lens here. And this really, you could say it took a lot of takes to try to get this image. But as you can see, so this is what the surgeon is seeing. So in my visual field, I see the field and I can click this on and off. And on the top, I see an axial representation as well as a CT representation. Now in real life, this LED image is very bright and clean. Obviously, this is taken through an iPhone through this lens, so it's a little blurry. But I think you get the idea, is that the navigation image is projected on the axial and sagittal view within my visual field. So as you're looking into the field, you actually see this on the top part of your field. And what's in green here is an overlay of the CAT scan over the anatomy. So you can see here the CT representation of the iliac crest actually superimposed over the iliac crest. You can see also the halo around, or the CT-based image around the previous pedicle screw. And you can see here also what's in yellow. This is the augmented version of the actual screwdriver and an augmented view of the actual screw itself. So when I'm looking at this, I can obviously see the real screw at the surface of the bone. But as it's going in, whether it's my resident or fellow, when they're placing that, I can check not only the anatomic accuracy and verify the starting point, but I also can look at what he's looking at or she's looking at with the axial and sagittal representation. And this is just a video showing some examples of that. So again, I'm watching my resident place a screw, and this is the first screw that he's placing. So he's going nice and slow, getting the feel of that. Again, looking straight down at the field, looking at the axial sagittal representation. Okay, so there you can see that in live action, sort of what that looks like. And, so it can be very helpful, especially in these revision cases where there's so much bone overlay and it's hard to see these landmarks. And like you see here, like I use power. So using power drills, obviously there are a lot of potential areas where things can go wrong. So what about beyond screw placement though? I think placing screws, I think that's great, but as we all know, whatever case you're doing, it's not the entire operation. You got to move on. And so does it take longer than freehanding? Of course it does. It absolutely does. And in the first several cases when we're doing this, my resident would ask me, this is really great technology, but to be fair, it's taking us a lot longer than we usually do using freehand technique. But like I said, I think in order to push the envelope and to really test out these technologies and see, what are the limitations, what are the benefits here, we got to start somewhere. And like I said before, I've been very interested in looking at novel applications of navigation beyond screw placement. And this was an article that we published in Operative Neurosurgery last year, looking at that, hey, what are surgeons using around the world in technical reports, case series, what are surgeons using, whether it's MIS or open surgery. And so this is a paper, we summarized that pretty nicely, I think, really giving an overview of some applications of that. But what about some future directions? I'm going to show some 2 quick case examples of that, and then hopefully we have some time for questions. What about tumor planning? So what about en bloc spondylectomies for tumor, whether it's in the mobile spine, or here, this is a case of sacral chordoma. In tumor surgery, it's not necessarily, I would say in the sacral chordoma case that I'm going to show you, I'm not placing instrumentation, but we need to be very mindful about the margins, right? Because as we know, getting an en bloc resection with negative margins is very important for local tumor control and has significant implications for that patient. And likewise, this is a craniocervical chordoma that I did recently. And is there a role for navigation to ensure, maximal soft tissue resection, finding the vertebral artery, mapping the vertebral artery, making sure the cuts are where we need it to be? And what about deformity? Here's a case of severe cervical thoracic deformity where I'm planning a 3-column osteotomy at the cervical thoracic junction. And is there a role here? How can I make these operations safer? Now, granted, these are not operations we're doing every day, but depending on where you are, the scope of practice, the type of hospital and the resources, we have to be well equipped to handle the single level TLIF to the radical en bloc resections and deformity cases. And so I'm going to highlight the cervical deformity case in that sacral chordoma. And we know this very well. This is some illustrations from great work that my colleague Chris Ames has done from UCSF showing, we all know what happens when cervical deformity occurs. And I love these illustrations. I put them in every talk, and I think it's helpful as a great framework to think about these cases. And this is a patient of mine who came in with severe cervical thoracic kyphosis. And this is where he is at baseline. This is, he's not in flexion. This is where he is in baseline, and shows you on the MRI here, there's no cord compression. So that's good. Very rigid spine. And you can see here that the sagittal C2 to 7 SVA is clearly in excess of 4 centimeters and his global alignment is impaired. So what can go wrong? I think all of us recognize that a lot of things can go wrong in these operations, including paralysis, uncontrolled bleeding, injury to surrounding structures. If we take that osteotomy too deep and breach that ventral cortical wall, yes, we can even get tracheoesophageal injury. A lot of bad things can happen. We planned this operation at the T2 level. You can imagine you can get pleural disruption, lung injury, can avulse, the subclavian artery. There are a lot of things that can happen here. Well, this is the setup. This is the case here. This is, again, in my operating room. The patient's prone on the Jackson table, and you can see the relationship of the head to the Jackson table. This is a view over top outlining. This is going to be from C2 to T10. With planning the 3-column osteotomy at the T2 level to really address that cervical thoracic kyphosis. And again, we've done that exposure. The head is at the bottom of the screen. And again, I'm placing that reference mark on a spinous process of the thoracic vertebra, distal enough so it's not in my way, but close enough to the T2 level that it's actually going to register and be accurate. And again, this is a visualization of that. This is right before we do our O-arm spin, and we're placing 2 of these trackers to maximize surface area of the imaging. And again, this is what my assistant is looking at. So right now, all the instrumentation is in. We've got our spinous process clamp here. And again, this is angled away from the field, so it's not, so we can actually see what's going on. I've done laminectomies above and below the area of T2. I'll show you a different picture of that. We've taken down the T2 rib heads, attachments to the vertebral bodies, as well as far out distally. So we've identified the pleura, preserved the pleura, and dissected all the way lateral to that T2 vertebral body wall circumferentially and around the T2 vertebral body safely. And this is what my assistant is looking at. Again, this is the axial projection. They've got a sagittal projection. And now we've attached the navigation to the drill, the Midas drill. And so now we're drilling the triangular wedge into the T2 vertebra, making sure that we don't transgress that ventral cortical wall. We don't want to breach that and sort of cause a translational defect. And we also need to be mindful of where that posterior vertebral body wall is, which I would argue is the hardest cut to make because we can't safely visualize that posterior vertebral body wall where it's really touching the dura. And you can imagine these cases where there's kyphosis, there is some ventral distortion of the thecal sac there. And this is just demonstrating how we do that. So again, this is the Midas drill that is navigated, and just using this to visualize the pedicle up top. You can see we're on one border of the pedicle, and drilling in real time, using navigation to go deeper and deeper into that vertebral body. You can see the relationships of the lung. You can see the tracheoesophageal structures going deeper, deeper. So, and anyone who's done this knows that that space is it's limited visually. There may be epidural bleeding. The pleura is there. The working channel is actually very narrow. And so having an additional point of reference for that distal, that deep cut is very important. And this is just a view of that. So now we've got a temporary, these are racks that are across the T1 and T3 screws. You can see the nerve roots exiting here. The pleura is on both sides. You can see the ribs have been resected all the way out on both sides. This is a large down-angled curette now that I'm using to make the final cut through the posterior vertebral body wall. It's been done on both sides here. And this is just a video now demonstrating the closure of that osteotomy that we're doing in real time, utilizing intraoperative neuromonitoring. Again, these are the exiting roots here. Okay, you have the exiting root here, exiting root there. The pedicle, the rib junction's been taken down completely. You can see there's relatively good hemostasis there. You can see the lungs inflating. Now we're closing that osteotomy down, and you can see the dura buckling slightly, closing, compressing on the retractors there, and also making that closure here. You can see here what that dura looks like when it's compressed. Okay, and this is what that looks like. The dura is buckling here. You see the nerve roots combined, close together, and this is our final construct with another rod across. And this is our intraoperative X-ray. You can see how we started at the beginning, and now with the closure, you can see the improvement in the alignment there. Again, this was C to the T10. This is a case I done fairly recently within the last month, so we don't have standing X-rays yet. But you can at least appreciate this is an intraoperative scoliosis X-ray, and you can see the extent of the correction of the curve there. My last case, I'm just going to show you just to wrap up in the next few minutes of the sacral chordoma. And again, there's no instrumentation here, but the implications are significant. And this is a low-lying sacral chordoma, and you can see its relationship. It's right abutting the S3 nerve root on the right side. And the question here, and this is the CAT scan demonstrating the lytic nature of this and its relationship to that S3 nerve root on the right side. And the question is, can I preserve that S3 nerve root on that right side, or do I have to sacrifice it? You know, I think that with a unilateral S3 and S4 nerve root resection, there's a very good chance that there will be potentially less impact on bowel and bladder function, but it is a possibility. And obviously we want to preserve roots when we can. But given the lytic nature of this, and you can see the extent of that lytic extension of the tumor right up to the inferior portion of that foramen, you know, I was thinking and planning, is there a way for me to make a cut right through that foramen that's going to be safe? And can I make a cut, preserve that root exactly where this yellow line is that goes lateral, sort of from the, like almost a 9 o'clock position on that foramen and out? Or am I going to have to take the nerve root because of the proximity? So that's what I'm thinking about here. This is a healthy person, no sites of disease, solitary lesion, completely neurologic intact. And that's what we're dealing with. And you can see here, even on the coronal, there might be a slight fracture or slight destruction of that inferior foraminal wall. And so going into this, I knew that I had to have a significant margin of soft tissue as well as bone around that. And this is our exposure. So again, this is a complete posterior approach. To the right of the screen is cranial, left side of the screen is caudal. I've done the laminectomy here. You can see these are the exiting sacral nerve roots here. We've got S2, S3, S4 in the middle there. And, you know, when I do this, I leave a significant cuff of tissue overlying. And this is where navigation is helpful, because even though we can count the sacral foramina, the dorsal foramina, because I'm trying to preserve as much soft tissue around this to get a marginal, negative marginal resection, I can't see all the sacral foramina. I can't count that. I've dissected all around. This is what this lap sponge is showing. We've dissected all around in that presacral space, separating it from that perirectal tissue safely as far as we can go around. And this is what this is demonstrating here. And I placed a pin, navigation pin, into the iliac crest. And again, positioning that navigation array away from the field so it doesn't get into where I know my hands are going to be, okay? And then we get our intraoperative CT, as I showed you before. And this is just a video demonstrating, very quick video demonstrating, you know, from skin incision, opening up here. We've done the dissection all the way around, safely dissecting away from that perirectal tissue. And now I'm using the navigated drill to drill at that level of the S3 foramen on that right side. I colored it with a surgical marker right before, but here I'm using navigation in real time as my assistant has a Woodson instrument just lateral to that S3 nerve root, and I'm trying to follow that. So he's showing me where the foramen is, and I'm trying to assess, hey, and then I'm doing this on the other side, but on my side, I'm trying to assess, do I need to take that root? And so you can see here, you can see how it's moving now. We've done all the cuts except for this one. And again, with that instrument, trying to do that. And eventually, I had to make a decision. I ended up sacrificing that root because it was just too close and was involved with the foramen. And you can see that we've sacrificed the root proximally here, okay? And again, this is just a picture showing what that looks like. So I have my eyes and hands in the field at the whole time, using navigation to guide that. And these are some screenshots showing that I'm at the inferior aspect of that. The tumor here, this is the lytic area. We're on to the right side of it here, seen on the navigation. This is right on top of the tumor. So again, remember, I have a cuff of muscle and fascia over that. So I'm right on top of the tumor. It tells me I should really move my instrument. And here on the other side of it. And this lets me see that at the top portion of it, I'm ventral. And remember, we've done the dissection all the way around, but again, at that higher level, at that S2, S3 level, you know, you can feel it, but you can't see it. And so that's where the navigation is helpful. This is an intraoperative x-ray of our specimen. You can see we're far above the level of the tumor, the lytic portion. We're below it. This is the coccygeal region here. You can also see on the coronal view or the AP view how close that lytic margin is to the foramen. You can see where my cut is relative to that foramen. And, I had to take the nerve root there. And again, this is the image. You can see I've got clips on the nerve root as it's coming out because the tumor, the extra osseous extent of the tumor, which is all in here, was abutting that. And this is the view at the end. So to wrap up, I hope this was helpful and illustrative of, how we're using augmented reality. And I love this image. I got this off of just the internet, Google search, because it really kind of pointed out to me, what other industries, what other people are using. And this is someone trying to land a plane at night on a runway. And you can see all the different tools used and measurements used to do something as difficult as that, and something that we may take for granted, something that patients may take for granted, that we can do all these things. We clearly can. And we've been doing this for decades, obviously, generations of surgeons. But, I pose it to this group as well as other surgeons. I think, we're obligated to keep advancing the field, and I'm, really curious to see where we can take this. So again, thank you very much. I hope this was helpful, informative, and you got something out of it. So thank you again.
Thanks a lot, dear friend, for this excellent nice presentation. Two questions on my mind. Can we use this facility in percutaneous interventions? The second question, can we start our training by this facility, or we have to start the training by conventional, then planning for this facility? Thank you.
Sure. Yes, this technology you can use for MIS and open applications. It's very well possible to do that. And I think that if you have exposure and you're used to using navigation, it's very easy to adopt this. I think what is a little different is, when you're wearing the headset, I think for those of us who wear headset lights or things like that, headlights, it's very similar to that. Although the orientation, I'll tell you, the first time I did this case, it did give me a little bit of a headache, because you have to get used to sort of what you're looking at, because it is a little bit of an overflow of information. But we have the capability of turning it on and off. And so I think that that's why I'm always curious for other people who've used this, what their learning curve was. So I think that, after you doing one or two cases, you very much get a sense for how to use it, what to look at. Sometimes I turn off the operating room lights because it's so bright in the field.
John, it's Michael. I have a question. So congratulations on the talk.
You can.
Thanks, Michael.
Yes. So can you perhaps compare and contrast this technology to robotics? So here you're using augmented, reality, which is, kind of in some sense has a kind of a similar concept to robotics, but I guess is different. So why have you chosen to go this route versus robotics? And can you maybe compare?
Sure. So part of it is from a practical standpoint, access, right? So at our institution, so at MGH, we don't currently have a robot. There have been a lot of talks about obtaining one, but it's a very practical side in terms of the capital needed to purchase a robot, the costs associated with such. And, at our place, not necessarily having a specific surgeon champion, who really wants to push it and utilize it. And so from a logistics standpoint, that was one thing. And I think that with obtaining this technology, it is very different just because it's less of a capital outlay. And I think that, in terms of various metrics that I think a lot of our institutions look at, it was easier to adopt. I think from a practical standpoint, I think for me, so I don't have personal experience using the robot, so I can't attest to the differences, but at least for this, I like it because it keeps the surgery in my hands and it lets me to play around with it and make the different kind of osteotomy cuts and things that I know you do as well in your practice, these type of cases. So, for me, it doesn't really disrupt my workflow too much because it allows me to keep my hands in the field,
Yep. Thank you.
Sure. Thank you.
This is the last question about accuracy of this technique in your hand.
Yeah, so I think that with anything, you're right. We're talking about minimizing complications and verifying accuracy. So that's why when I started using this in these cases where we're doing revision operations, you know, I was actually able to we have to verify it frequently, but also a tool that's helpful is when there's hardware inside the body already, I can actually place it within the screw tip, the tulip, and I can see on the screen that it's still accurate. I think in that chordoma case that I showed, obviously as the tumor is moving around, you're going to lose accuracy. So I didn't really use it at that point. But I think that, you know, in that chordoma case, you know, this case had negative margins. We reviewed it with pathology, and there was nice margins, so it was accurate to that standpoint. But I think with like any of these, we have to just build experience and then be transparent about it and report it. You know, and that's what we're doing right now. You know, consecutive patients across different applications, and just be honest and share what, you know, our experiences are.
Okay, Sam.
Okay, I think we lost Shem. Thank you, Professor Shem, for this excellent presentation. And now we will shift to next speaker, Professor Michael Failing. Please, John, start sharing his lecture. Thank you.
Okay.
I'm Professor Michael Failings from the University of Toronto, and I'm very pleased to join you virtually in this session sponsored by the Egyptian and World Neurosurgery Committee Academy. And it's indeed an honor to take part in this session. I'll be speaking about the challenge of mild degenerative cervical myelopathy, and I'll be stimulating you with some new knowledge related to the applications of genetics, machine learning, and advanced microstructural MRI, as well as some pearls around clinical decision-making to allow you to personalize management recommendations for these patients. At the outset, I'd like to thank Drs. Atul Goel and Dr. Sameh Morsi for their kind invitations to take part in this session today. And I hope to see many of you in person as the COVID-related travel restrictions ease. I have no relevant commercial disclosures, but I am the principal investigator on a number of clinical studies and guidelines that I'll be making reference to. In 2015, we coined the overarching term degenerative cervical myelopathy. This encompasses a variety of benign, non-neoplastic, non-traumatic pathologies that cause progressive cord compression. And importantly, this synthesizes two of the commonest entities, namely cervical spondylotic myelopathy and ossification of the posterior longitudinal ligament. The pathophysiology is defined by the confluence of static factors causing compression of neural elements as well as ischemia, dynamic factors, which include dynamic compression, axial tension, deformity, and instability, as well as biomolecular factors related to intrinsic neural damage. And these include inflammation, ischemia, and excitotoxicity. One classifies the clinical presentation of degenerative cervical myelopathy using the modified Japanese Orthopedic Association scale. And this report shown on this slide is the validation of this metric. And so one looks at upper motor dysfunction in the upper extremities, motor dysfunction in the lower extremities, sensory dysfunction, as well as sphincter dysfunction. And mild, moderate, and severe are shown in this slide. In 2017, in the Global Spine Journal, we published for the first time guidelines on the management of degenerative cervical myelopathy. This is one of the key data slides from the systematic reviews that provided the evidentiary basis for some of the guidelines recommendations. And this shows the important impact of surgery on short-term follow-up, intermediate-term follow-up to 3 years, and long-term follow-up beyond 3 years. And this shows very large effect sizes and narrow confidence intervals, indicating very strong effects in general for surgical decompression. So for moderate and severe degenerative cervical myelopathy, surgery is clearly indicated as the preferred management strategy. But things start becoming a bit more gray with mild degenerative cervical myelopathy. And here, depending on the clinical presentation, one might suggest a course of non-surgical treatment with structured rehabilitation and careful follow-up, or depending upon patient wishes and surgeon judgment, surgical intervention. And here's really where the art and the uncertainty comes in. So mild DCM represents a key knowledge gap, but also an opportunity for innovation. So I want to share with you some pearls that will allow improved clinical prediction. We are now starting to get a better understanding of the natural history of mild DCM, but this remains an area that we need to define further. We need improved outcome measures, as well as biomarkers. And I'll present microstructural MRI, in particular T2 star, white matter to gray matter ratio measurements, as well as various genetic biomarkers as key potential tools. So let's discuss a case. So here's a 67-year-old woman. Here are her sagittal MRI scans, which show a moderate degree of subaxial spondylosis with cord compression. She's presenting with mild neck pain. She has bilateral radicular arm pain, mild hand weakness. On physical examination, she did have early myelopathic features, and we judged her MGOA to be 15. So she was in the mild range, but clearly myelopathic. Here are her axial images at C5, C5-6, and at C6-7. So let's consider 3 clinical scenarios. Let's imagine now that this patient comes to see us and she has minimal neck pain, but she does have cervical stenosis, but she has no neurological symptoms and signs. So that's one presentation. Let's now imagine the patient has minimal neck pain, but has evidence of a cervical radiculopathy, so with arm pain, neurologic symptoms and signs, and cervical stenosis, but no evidence of myelopathy. And now let's imagine this scenario that I've presented, where the patient does have evidence of early myelopathy. So how do we advise the patient, and what will be the correct decision-making? So again, we need to recognize that DCM is a form of progressive slow motion spinal cord injury. Some patients have a benign prognosis, but certainly many patients do not. And there are age-related degenerative changes in the cervical spinal column. These cause progressive cord compression. There's spinal cord ischemia, inflammation. This can result in neurological disability and functional deficits. And so we recognize that the earlier you manage the patient, the better they will do, but not all patients show progression. Now here's another example. This is a patient here with a mid-sagittal MRI scan. There's T2 signal change within the cord parenchyma. And again, what if this patient comes in with neck pain and no myelopathy, radiculopathy, or a minimal myelopathy? In other words, the 3 scenarios that I've painted. Well, here's one pearl that I will leave you with. Microstructural quantitative MRI is with us now. And I'll present to you a tool that any of you can use with your neuroradiologist in your clinics. There are many tools that are available, and you should become aware of these as well. T2 weighted, T2 star weighted imaging to look at atrophy and compression, magnetization transfer ratios to look at demyelination, DTI and fractional anisotropy to quantify axonal injury, as well as T2 star weighted white matter to gray matter ratio. And this is the one that I think is particularly valuable. Julien Cohen-Haddad in Montreal has established a spinal cord toolbox. This is freely available online. This is a helpful tool for your neuroradiology teams to use in the analysis of these images. And this is the paper to which I'm referring. This is the description of the T2 star weighted white matter to gray matter signal intensity ratio. And here's what the images look like. And you can also separate the tracks using a Cohen-Dodd's spinal cord a toolbox. And this metric is very easily done. It's a very simple ratiometric measurement, and it correlates with clinical presentation and is predictive of neurological deterioration. And this is what we're trying to prevent. So here's a normal spinal cord shown in cross-section, and here's what it looks like in the setting of degenerative cervical myelopathy. There's significant atrophy, there's astrogliosis in the dorsal horn, loss of white matter, demyelination, and axonal loss. So we want to try to prevent this. We recognize that spinal cord injury is a progressive phenomenon with cord compression, resulting in ischemia and subsequent injury to the vasculature, as well as loss of neurons, axons, and ongoing inflammation. The MRI can provide some helpful clues, even a conventional MRI. So diffuse T2 signal change, this is where you have long segments of T2 signal change, and segmental T2 signal changes, where you see these skip lesions, are associated with a poor baseline status and outcomes. So these are bad actors. And if you see a patient like this, they certainly are at high risk for progression. So in this focus issue, we looked at the various treatment options for degenerative cervical myelopathy, and there are excellent treatment options available. And we also recognize that the natural history of cervical myelopathy is not so great, and there are many patients that do decline over follow-up. In patients with cervical stenosis and no clear evidence of myelopathy, the presence of EMG or clinical symptom signs of cervical radiculopathy is predictive of neurological decline. And certainly these patients should be counseled about this risk, and I will recommend surgery to these patients. So here are the AO Spine CSRS guidelines again, and the quandary we have is really in the setting of mild degenerative cervical myelopathy, where the evidence to support management is relatively low, and only a weak recommendation could be made. So we're trying to balance the risk and the benefit of surgical treatment in these patients. This is a study that we published a few years ago, looking at the efficacy and safety of surgery for mild DCM. And this is a combined data set from the North American and international AO studies. So one of the important lessons here to learn is that patients with mild degenerative cervical myelopathy have a surprisingly significant degree of impairment on the SF-36. So you'll see here the population norms are around 80, and you'll see that there's a dramatic impairment in both the physical and the mental component scores on the SF-36. Surgical decompression does improve function, disability, and quality of life in patients with mild DCM, but this is a heterogeneous group. And two of the things to pay attention to are neck and arm pain. You can quantify this using the Neck Disability Index, as well as functional status. And here you can look at the SF-36 physical component score and mental component scores to guide your management. Now, if you apply machine learning and artificial intelligence algorithms, one can derive a principal component analysis. And many of these factors cluster together. So in patients with mild DCM, negative predictors of outcome include older age. So patients who are older tend not to enjoy as good a recovery of function. It may be reasonable to watch these patients. Medical comorbidities and smoking. So it's advisable to counsel patients to stop smoking. And interestingly, in this milder group, it's generally preferred to do anterior approaches, and it seems that the pain outcomes are better. So if we look here again to create an algorithm around mild DCM, the critical things to use in your clinic will be the SF36. So if patients have a lot of impairment on the SF36 and or they have significant pain as assessed by the Neck Disability Index, they will be very responsive to surgical decompression. And these are the patients that will really benefit. So let's come back now to the patient that I managed. So she did have evidence of an early myelopathy, and I did counsel her towards surgery. I was concerned by the fact that although she had mild DCM, she had an MGOA of 15, so almost in the moderate category, and she herself felt that her life was quite impacted by this. And again, these are the axial images showing significant multi-level cord compression. And I managed her with a multi-level anterior cervical discectomy infusion. She had an excellent outcome, MGOA 18, completely free of radicular myelopathic symptoms and signs. So fortunately for this patient, an excellent outcome. Importantly as well, mild DCM may not have such a benign prognosis. And when we looked at a cohort of patients in our clinic, largely with mild DCM who declined a surgical intervention, over 50% of these patients ended up requiring surgery within about 2 years. And conventional MRI was relatively insensitive to detect change. So here really, it's listening to the patient and doing a careful neurological examination and a clinical history. Now, genetics may play a role going forward. And here is a snippet of data on the ApoE4 allele. And ApoE4 is related to a lipid and cholesterol metabolism, and it's critical to the physiology and normal functioning of neurons. ApoE4 has been linked to the development of Alzheimer's disease. Most patients have an ApoE3 allele, which renders them less susceptible to neuroinflammation. But the presence of an ApoE4 allelic status in a clinical series from our unit was clearly associated with worse neurological recovery after surgical decompression. And so this may be a very appealing genetic biomarker to look at. So in conclusion, surgical decompression is safe and effective for mild DCM, but mild DCM is heterogeneous. Pain, unsteady gait, weakness are associated with greater baseline impairment. And importantly, pain, and when patients perceive that they have significant impairment at a functional level, this is associated with greater gains. And in general, we counsel toward an anterior approach. The SF36 is a useful instrument and may help classify patients in your clinic as to the ones that may benefit from surgery. So let's come back to the three scenarios. So with neck pain, cervical stenosis, and no myelopathy, surgery is not indicated. Careful observation and counseling of the patient is the way to go. With neck pain and evidence of radiculopathy, in general, I will recommend surgery because these patients are at higher risk for the development of progressive myelopathy. And with neck pain and early myelopathy, I would recommend surgery if the symptoms are having an important impact on quality of life. Future decision analysis will benefit from new approaches, including machine learning, microstructural MRI, and genetics, and I present you the ApoE4 assessment as a potential tool. And on that note, I'd like to close. Thank you for your attention, and pleased to address questions.
Thank you, Professor, for this excellent presentation. We have 5 questions from Professor Felling, and I will start sharing it on the screen. Please answer it on the chat box. This is the first one. Degenerative cervical myelopathy is classified into mild, moderate, severe presentation based on which of the following: clinical impression, neck disability index, modified Japanese, NOIC scale, extent of code conversion.
Hey, Sam, where are we going with this?
Answer it in chat box. Hello.
Dr. Same, did you want me to go over the answers after you go through the questions?
Yes, sir.
Okay, I will be pleased to do that.
Okay, thank you, sir.
Sam, Uday Gupta has a question. Do you see that?
Okay, we will ask it after finishing these questions. Okay, next one. In patients with cervical cord compression, an MRI, but no evidence of myelopathy, surgery is a veiled option in which of the following scenarios? All patients with cord compression on MRI should have surgery, regardless of whether there is frank myelopathy due to risk of spinal cord injury. Patients should only have surgery if there is T2 signal change. Patient with the cervical radiculopathy, clinically or electrophysiologically, are at high risk of developing cervical myelopathy, and hence surgery is a veiled option. Surgery is never indicated in this patient. Okay, next one. Which of the following is the correct answer regarding mild degenerative cervical myelopathy? Neck pain and or arm pain is all key driver for patient to desire surgery. Many patients with mild DCM have surprisingly significant functional impairments, as assessed by SF36 score. Surgery is effective in improving pain and the quality of life in patients with mild DCM. None of the above, all of the above. Last one, which of the following shows promise as a biomarker to guide decision-making in patients with mild degenerative cervical myelopathy? Serum GFAP levels, serum albumin, T2 gray matter white matter ratio in MRI scan, ApoE4 versus ApoE3 Alex status, C and D are both correct.
Great. So perhaps, Dr. Same, we can go back to question 1, and I'll just walk through the answers while we're doing this. There was a question from Dr. Gupta around the role of surgery for moderate cervical myelopathy. And the overarching answer is yes, that surgery is recommended. And patients who progress from mild to moderate myelopathy are at quite high risk to become, to have a more severe neurological progression. So I think it's advisable to, in general, to operate on these patients. Can we go to question 1, Dr. Sami? And this really had to do with the classification of cervical myelopathy. So all of the factors that I showed in question 1, I don't know if you can share your screen to show question 1, but all of the factors, including the severity of cord compression and imaging changes, your overall clinical impression, these are all important factors, but the way we classify cervical myelopathy and what is referred to in the current AO Spine CSRS guidelines, published in 2017 in the Global Spine Journal, these reference to the classification based on the modified Japanese Orthopedic Association scale. So with regard to our lecture today, mild DCM is 15 to 17, and then moderate is 12 to 14, and then severe is 11 and less. And then the second question, I believe, related to decision-making kind of in mild myelopathy. So the current recommendations are that even if there's cord compression, if the patient doesn't have symptoms of preferable to observe the patient. The key driver for recommending in a non-myelopathic patient to have surgery is if they have radiculopathy. And EMG, electrophysiology, can be helpful because sometimes it's a bit tricky, particularly with upper shoulder pain, to figure out if it's true referred pain or not. But patients who have a cervical radiculopathy will be vulnerable for the development of cervical myelopathy. And then in terms of the decision-making in mild myelopathy, from the patient perspective, and what's actually quite helpful in the clinic is for you to recognize that the two key drivers that will drive patients to want to have surgery, even if they're only mildly impaired, is one, if they have significant pain, either neck and or arm pain. So that's one key driver. And then the second key driver is if the patients perceive that they're quite impaired. And so it's quite easy while the patients are in your waiting room to get them to fill out a couple of questionnaires. One, you can assess their neck disability index, or NDI. And if they've got a lot of pain on the NDI, then the patients will likely want you to operate. And then the second one is if they have a lot of impairment on their health-related quality of life. And then we had a question then on the biomarkers, and this was just try to get you to think about these. So the T2 star, white matter to gray matter ratio, is a very easy one. all clinical units, even at 1.5 Tesla, all of the manufacturers do have the software to run the T2 Star. And the radiologists currently do this, but they don't necessarily tell you they're doing it. So you can request the radiologists to do a measurement of the T2 Star white matter to gray matter ratio. We have the paper, and if you email me, I'm happy to share the PDF with you. It's very easy to do. And so it's what we have found is in the patients with a mild DCM, it's predictive of the patients which will show down the road problems. And then the ApoE4 allele, it's very easily assessed genetically. We're not doing it very much right now, but it is a genetic marker that's associated with a variety. They have repeated concussions and post-concussion issues are at much higher risk if they have an ApoE4 allele. And ApoE4 is a significant risk factor for the development of dementia of the Alzheimer's type. And we now, in the paper that I referred to, which was published in Brain, it is a risk factor for the development of cervical myelopathy. So it's just something for you maybe to think about. And I would encourage all of you to, to potentially look at this in your practices. And just looking at the questions. So I was asked a question, which I answered in the Q&A on rehabilitation. So rehabilitation is a reasonable option if patients are coming in with mild myelopathy and they're not so keen on surgery. There's not truthfully any rehabilitation protocols that have been actually shown or proven to make an impact, but it's a reasonable thing to try to do while you're watching the patient. So, people are keeping an eye on them. And then I do encourage the use of rehabilitation as an option post-operatively. I think it's quite helpful. And I suspect most of you are also using this. And then in the chat line, I just saw that Dr. Gupta had a question on moderate DCM and the patients coming in with 2 or more years of symptoms. And I guess there are 2 points here. So one is that in general, patients with moderate DCM should have surgery unless there's they're too frail or have too sick or something. But in general, most patients should have surgery. And then I guess the implication from the question, I think, is it too long a period if they have 2 years of symptoms? And to be truthful, that's actually pretty typical. It's not ideal, but it's actually quite common for the diagnosis either to be missed or underplayed. And so certainly if someone came into my clinic with 2 years of symptoms, I would offer them surgery. I would have a discussion to indicate that ideally we would want to operate on people kind of earlier on, and there may be a kind of a reduced likelihood of seeing major improvement, but we do see significant improvements even in that scenario.
Thanks a lot, Dave, also for accepting our invitation and for this valuable lecture and questions. Thank you. And now we will shift to next speaker, Professor Louis Lucien. Please, John, start sharing his lecture. Thank you.
Sorry there, Sam. Let me get it. Hold on. Okay.
I want to express my gratitude for the kind invitation of Dr. Samer El-Morsi Hassan and the EWNC to participate in this magnificent event. I am Luis Miguel Duchenne Rodriguez, neurosurgeon from La Paz, Bolivia. Today, I will show you the functional results, the administration of ozone and plasma-rich implantals as treatment for low back pain in lumbar disc herniation. Low back pain is a disorder with a significant impact of the clinical status for patients with socioeconomic and public health consequences. In 2016, the United States spent $134.5 billion for the management of patients with low back pain. Intradiscal administration of mixed ozone and platelet-rich plasma is a minimal invasive and low-risk alternative for the treatment of pain caused by herniated disc. The objective of this work is to determine the functional result of the administration of ozone and PRP in patients with low back pain and low back pain with radicular radiation secondary to lumbar disc herniation. This is a longitudinal prospective study for January 2016 to March 2020 that included patients with low back pain and low back pain with radicular radiation who underwent intradiscal phase induced perpendicular and epidural flow rate injection ozone and platelet-rich plasma under fluoroscopy, local anesthesia, and sedation on one-time outpatient basis. They were evaluated pre-intervention visual analog scale and Northwestern disability scale at weeks 1, 2, 24, 48, and 86. Magna criteria are years after the intervention. The inclusion criteria were lumbar and radicular pain caused by protruded or extruded disc herniation documented with MRI. Failure or conservative treatment performed for 6 weeks. On the other hand, the exclusion criteria were Cauda-Equina syndrome, motor deficiency, sequestered or intradural herniation, previous spinal surgery, concomitant spinal tumor, traumatic or infection disease, spinal instability, coagulation disorders, hyperthyroidism, infiltration with corticosteroids and the last 6 months, pregnancy, serious psychiatric illness, medical legal disputes, use of anticoagulants. All patients were prepared with cardiological evaluation, preoperative labs, lumbosacral MRI, lumbosacral dynamic radiograph. All signaled a written authorization for the procedure. Blood was obtained at venoculture and use of percutaneous. The blood is then centrifuged and the platelet-rich plasma is separated in laminar flow chamber. In the operating room, the administration of ozone and PRP is performed under sedation and local anesthesia with fluoroscopic guidance using Chiba needles with the patient decubits. In these images, we can observe the administration of ozone and PRP under strict antisepsis. We can observe the insertion of the needle into the L4, L5 discs. The knees increase the height of the L4, L5 discs after administration of ozone and PRP. Then needles in fascial joints and finally the needle in epidural space through the sacral hiatus. The range of fascial joints and epidural space, 22G spinal needles are used. This imaging shows the change of the intervertebral disc comparing the state before the intervention of 4 weeks and 12 weeks later. It's important to note the portion of extruded disc is or that reduced in size. The imaging shows that the non-extruded portion of the disc doesn't dehydrate after the procedure and even a slight increase after 12 weeks. Axial images show the reduction of disc and reduction of rod compression. There seems to be some space between the nucleus pulposus and the annulus fibrous in the imaging after 12 weeks of treatment. We included 55 patients, 24 women and 31 men. Average follow-up was 25.84 months. 78 patients presented log 1 pain with radicular irradiation, 22 axial log 1 pain. Rating the treated levels, the majority, 51%, were L4, L5, and L5S1. We evidenced a clear reduction of the BAS values from the first week, which remained sustained until 96 weeks. Similarly, the value of ODA decreased drastically from the first week and remained until week 96. The values of the MAGNAF scale show 85.5% of favorable results, excellent, and good. Currently, there is a lot of literature of variable quality that supports the use of some in PRP for pain due herniated discs. We will review the most significant. Ozone is an inorganic molecule with allotrope properties consisting of 3 atoms of oxygen with cyclic structure isolated for the first time in the 839 for Christian Friedrich. Ozone is present in the nature in the smart forest, but also produced artificial by subjecting the atomic oxygen to high voltage electrical disgrace and appears colorless in gaseous form with a characteristic smell. Unfortunately, it cannot be stored because the ozone is high in stability. Moreover, the medical gas mixture concentration, solid composite, is no less than 95% to oxygen and no more than 5% of ozone. Several papers suggested several medical features of ozone, including bactericidal and virucidal properties, inflammatory modulation, and circulatory stimulation. Ozone effects on the inflammatory cascade interrupt breakdown arachidonic acid to inflammatory prostaglandins, leading to decreased pain. Inhibits the synthesis and release of pro-inflammatory cytosine was prostaglandins A2 and bradykinin. It stimulates release and anti-inflammatory cytosines. Generates hyperoxygenation. Derive reduces pain by direct and indirect mechanisms, increasing tissue oxygenation by 2-3 diphosphoglycerate within the erythrocytes. Choledacry is what achieves breakdown of glycosaminoglycan while reduces ability to hold water, which turn leads a significant drop of intradiscal pressure, nerve of life. In our opinion, this dehydration only occurs on the extruded disc. The non-extruded disc maintains its hydratation as shows this MRI. Ozone will also proceed with stimulation of fibroblastic activity, which allows repair process by stimulating collagen production. The other hand, PRP is autologous blood concentrate that relates abundant particles contain high concentration of proliferation and differentiation, promoting growth factors. Triggers a serious change that promotes the tissue repair. Activated pellets releasing growth factors and adhesion molecules mediate a varied cellular interaction, chemotaxis, cell adhesion, migration, cell differentiation, and stimulate to immunomodulatory activities. This platelet cell-cell interaction, activated platelets releasing growth factors and adhesion molecules mediate a variety cellular interaction, chemotaxis, cell adhesion, migration, cell differentiation, and stimulate to immunomodulatory activities. This platelet cell-cell interaction contribute to angiogenesis and inflammatory activities, ultimately to stimulate tissue repair process. Of the multifaceted 5-hydroxytryptamine responses following inflammatory PRP, after platelet activation, platelet release their granules, including 5-hydroxytryptamine from dense granules, inciting a wide range of differential effects in various immune, endothelial, and smooth muscle cells. Activated platelets release many pro- and anti-inflammatory mediators that are proficient and inducing pain, but can also reduce the inflammation and pain. The injection on PRP is effective to enchasing extracellular matrix accumulation, retaining a high disc height index, increasing the T2 signal intensity, and slowing the process and possibility reversing the effects on intervertebral disc degeneration. PRP is anti-apoptotic, set proliferation, and anti-inflammatory effects that increase the synthesis of collagen and aggregants they manage to maintain to a decay where they contain that restores the elasticity and height to the disc. In this study, 80 patients were divided in 4 groups of 20 patients. Lumbosacral CT is performed and interleukin 6, AGM, AGG, and superoxide dismutase were tested. A control group maintained and different concentration of ozone were administered to the others. CT shows that the 40 micrograms ml group had a great reduction of volume of extruded disc. The same group present great reduction of concentration for interleukin 6 and AGM. It also showed the reduction of AGG and increased the superoxide dismutase as evidence of increasing the antioxidant activity. Of the value of the BES as also better the 40 micrograms group. It followed the appropriate dose of 40 micrograms ml. This other study showed that doses of concentration of 30 and 40 micrograms ml had same clinical results. This paper showed that effectiveness of ozone is sustained follow-up to 10 years. This group of items including 3,500 patients achieves 75 to 8 good results. This British journal shows functional results similar to those obtained by us. I must emphasize that ozone was administered not only in the discs, but also the facet joints, paraganglionar, and paravertebral levels. This Italian study identified success predictors: pain duration lasts less than 1 year, MSU tip of disc herniation 1A, 1B, 1C, 2A, and 2B, disc degeneration grade 2, and absence of foraminal stenosis are associated. The Spine Journal published a multi-center pilot prospective randomized control trial conducted of 3 European hospital spine centers comparing the ozone administration with microdiscectomy. Identified that there are no significant difference between the functional result obtained with microdiscectomy and intradiscal ozone administration. This study randomized patients into the 3 groups: surgery, ozone administration, and oxygen administration, establishing that only 20% of patients receiving ozone required surgery versus 60% of those receiving oxygen, which drastically reduced to the cost and hospitalization. This double-blind study shows that corticosteroid no is necessary when intradiscal ozone is administered. This paper shows that there is no difference in 3 and 6 months if we compare ozone, foraminal corticosteroid, and pulsed radiofrequency. Stefan et al. Establishing on this meta-analysis that oxygen ozone therapy is effective and extremely safe, achieving pain reduction and improving function in patients aged between 33 and 94 years with all tips over 90 discs. In addition, they established that the improvement in pain and function are similar to results obtained with discectomy with much higher complication rates. Ribeiro et al. In this systematic review with meta-analysis and randomized study established that ozone is more effective than other therapies to management the low back pain. On the other hand, this study shows functional results to the administration PRP and similar dose of ozone. The Belgian study establishing that PRP is safe therapeutic solution with a very positive cost-effective and simple relationship to implement, and that no human studies have reported negative side effects. This North American group establishing good results to pain control with PRP after 9 years of follow-up. This New York study conducted a prospective randomized controlled double-blind study with inclusion and exclusion criteria similar to ours. They found evident improvement in functional result after the administration of PRP versus contrast alone. This Euro-Asian randomized double-blinded controlled study comparing PRP and corticosteroid on the management of degenerative spinal pain showed the superiority of PRP. This meta-analysis showed the effectiveness of intradiscal PRP to the management of discogenic low back pain. In summary, ambulatory multimodal percutaneous administration of ozonal PRP achieves pain relief in patients with low back pain and low back pain with radicular redegeneration by regulating the inflammatory processes and reducing the volume of the degenerative nucleus pulposus in patients with lumbar dissection, level evidence 1 ++ for PRP, 1- for ozone. In conclusion, the multimodal administration of ozone and PRP is effective and safe to treat patients with low back pain and low back pain with radicular redegeneration secondary to lumbar dissection in selected patients, achieving good functional results measured with BAS, ODA, and MAGNAP. Thanks for your attention.
Thanks a lot, Professor Lewis, for this excellent presentation, which is augmented with multiple research papers. Is there any question from panelists?
Yes, thank you for this presentation. I think the most important is this approach, the relief of pain relief. At first week, it's very interesting. But MRI at 4 months, we know that without any treatment, if we do an MRI, we show disappears. There's no herniation, disc herniation.
Luis, you can hear Louis, the question?
No, my signal is not good. You can write the question in the chat, please.
Yes, okay. Yes, okay. I will do it.
Please. Yes.
Okay.
Okay, while we're waiting, let me ask a question from Inad Canal. It says, you said that previous surgery was exclusion criteria. What is the reason? Did you understand, Louis? Can you hear me okay? Maybe not. Okay. Okay, the question is in the chat. Do you see the question, Louis? This is not working great, Sam.
Write the question, please.
Can you see the question in the chat, Louis? There's a couple of questions there.
Okay, Professor Lewis, you can answer it again on chat. And now we will shift it to next speaker, Professor Kakondo. Please start sharing your screen.
Thank you, Sam. Thank you, John, for inviting me here. It's really a pleasure to be here in this distinguished symposium with so many titans of spine surgery. Are you hearing me okay?
Yes.
Great. I'm going to optimize my screen for video sharing. And so I know the title of this symposium is Revolution in Spine Surgery. I'm here to discuss and to talk about endoscopic spine surgery. That's really an evolution to a revolution, not only a limited time where we do a great change, but it's been like, I think this more than 30 years of evolution in endoscopic spine surgery, and we will try in the next minutes to cover that history. First of all, I don't have any financial disclosures regarding this topic. So the first things that you have to know is that endoscopic spine surgery is not really a new technique. Started in the early 90s as a way to take advantage of 1976 approach described by Cambing. You know, that's the really famous Cambing's triangle. And the idea of endoscopic spine surgery, the first generation of endoscopic spine surgery, was to take advantage of that anatomical window to access the foraminal and intracanal disc herniations. But the limits in the technical skills of the surgeons and in the technological advances, there were really high. So the only thing that the surgeons in the early 90s can do is to do what they called the iceberg technique. So I don't know, you can see my pointer here, yeah? So they will go into the center of the disc and take out the center of the disc, and they expected to lower the disc herniation by lowering the disc pressure. So that, of course, it was a really rudimentary technique, and the only indication that they have is that to treat foraminal and intracanal pathology using the foramen as an anatomical window. So what happened is that there were several limitations and contraindications to the transforaminal access. For example, if you're thinking about using the foramen as an anatomical window, if you had a severe foramen stenosis, you with the first generation of transforaminal access, you weren't able to get into the pathology. I mean, you were risking to damage the exiting nerve root. And the same thing happened with the migrations. If you have a hernia that was with a high migration, I mean, like caudal migration hiding behind the pedicle, or maybe a cranial migration, like going into the axilla of the exiting nerve root, it was really hard to access it with a transforaminal access. So this first generation of transforaminal access was really limited to the disc pathology and to the disc pathology that was in line with the disc space. We don't have to forget that until this point, the endoscopic surgery was a needle-guided surgery. You put the needle, then you put the dilator and the working sheet, and you put the endoscope right in the place where the needle was, and that's all. You can go a little further, a little backward, but that the direction of your endoscope was limited by the needle trajectory. So the thing is that there's a series of complications with this first generation transforaminal access that were related to the refers to the damage or maybe mobilization of the dorsal root ganglion. The first reports talks about a 36% of post-operative dysesthesia. You know, this is a really annoying symptom for the patient and for the treating physician, and really obscured the results of the discectomy. There was also a great deal of hernia recurrence because the amount of disc that you took out was not good enough with this iceberg technique, and the hernia remainings was really a problem too, because if there was a loose fragment in the canal and you just accessed the main fragment, there's a risk of leaving a fragment behind. So what happened is that a lot of technological advances started to grow, to appear. Kerrison punches, trifines, drills, endoscopic drills that mimicked the armamentarium we have in open surgery in endoscopic surgery. And these technological advances were followed by some degree of expertise and technical advances in the endoscopic spine surgeons. We were able to shift from iceberg technique and going deep into the disc, the so-called the in-out technique, to the out-in technique, where we go from the outside of the disc, just searching the extruded fragment and releasing the nerve root from the transforaminal axis. With the help of drills, we were able to drill the anatomical boundaries of the foramen and widen the foramen to make a safer aspect, a safer access for these herniations. The thing is that if you look at the evidence, that kind of improvements expanded the indications, but they didn't reduce so much the complications that we were talking about. I think that, and this is a personal belief, I think that the game changer was the presentation in the 2006 of the interlaminar approach. It's funny that this approach that uses the same anatomical landmarks that we use in open surgery were groundbreaking in endoscopic surgery. So the thing that Rutten and Comp and Godolias did is that they used the same equipment that was used to do transforaminal access to do a interlaminar access. So what you have here is the basic interlaminar access to access this herniation at L5S1. This is a voluminous disc herniation, and our idea is to go with the endoscope through the interlaminar window, trying not to drill or alter the bone tissues, but only opening the flavum ligament, like you see here, identifying the nerve tissues, like you see here, and then unroofing the lateral recess where the nerve axilla is, the nerve shoulder is. So what you are seeing here is this is a really nice maneuver of nerve root relaxation with the working sheet that allow us to go into the disc space by mobilizing the nerve root. So we do an annulotomy. We use our hook to release the hernia, and then we took out the hernia. It's amazing how big these fragments can be. It's usually like this or bigger. And if we are not happy with the decompression of taking out the the fragment alone, we can go and take out an osteophyte like this with a chisel, or you can drill it with a diamond burr. It's really safe to drill with the protection of the working sheet and release the nerve root like this. You know, this is the final view. You can mobilize freely the nerve root. You can watch the disc space, and that's the flagellum ligament window, and this is the hernia that we extracted. So this is the basic of interlaminar approach to the lumbar spine. And that's what's really groundbreaking, because it allowed to treat a number of pathology other than these herniations, and overcome some anatomical limits, like high iliac crest to go into the L5S1 space, and some revisions and papers show that actually the recurrence of the herniation was less when you use interlaminar approach. But the thing is that when even with the advantages of interlaminar approach, you had like two compartments that were outside the reaches of interlaminar approach. That was foraminal and extraforaminal zone. So the thing that happened is really interesting, because interlaminar approach demands more freedom of movement and maybe more skill to the endoscopic surgeon. When you are doing an interlaminar approach, you're no longer limited to the disc space. You have to be able to navigate through the anatomy with your hands, with the endoscope. And the thing that happened is that the surgeons started to do the same thing that they do in the interlaminar approach with the transforaminal approach. So they copied the maneuvers that they were using in interlaminar approach into transforaminal approach, and the result was marvelous, because we were able to treat pathologies that we weren't before. You know, this nice lady with the R4 nerve root pain, just going into the foot, and look at this listhesis compressing the L4, the L5 nerve root, with mainly because of the osteophyte, and it's a stable case. The dynamic X-rays didn't show any movement. So our strategy here was to go first into a safe zone, that's the SAP of L5, and then navigate under endoscopic visualization until we reach the pedicle, and then the L5 osteophyte. So this is only possible because we have the ability to navigate and the freedom of movement that we learned in the interlaminar approach. So when we get to the osteophyte, we will remove it, access to the disc space, and then remove the L4 osteophyte, and then release the soft tissue that is compressing the L4 nerve root. So look at this. This is the axis. I think this is a really nice way to approach a troublesome foramen. We go into the SAP. We used to go directly into the disc space, and that was really dangerous for the exiting nerve root, because what we observe is that sometimes we damage the exiting nerve root with the puncture needle. So from, I think, 3 years from now, we are going into the SAP and then navigating from the SAP to the disc space under endoscopic visualization and checking out that the exiting nerve root isn't in the way of the endoscope. And the percentage of post-operative dysesthesia has lowered a lot. I think we have like 2 years post-operative dysesthesia free since we started doing this approach. And the idea is to navigate under endoscopic visualization, like I said before. So here's the first view. You have the SAP. We are going to navigate to the foramen. And this is, I think this is a nice view. You have like the L5 SAP here, the nerve root in close proximity with the L5 osteophyte going from the end plate that we are aiming to remove. So we're going to start like protecting the nerve root with the working sheet and drilling the center of the osteophyte. The idea is to cavitate the osteophyte and then fracture it from the outside to the inside, and then remove the osteophyte with a Kerrison punch, protecting the nerve root in every step. We are going to drill here from lateral to medial to make sure that the whole extent of the osteophyte of L5 is removed. That's a diamond board. This is an eye combination of technique and technology together. And you're going to see that here the disc space is becoming visible. That wide line in there is the disc space. And now that we have achieved the level of L4 due to the listhesis, we are going to go for the L4 osteophyte that's compressing the L4 nerve root. So we are going to drill the L4 osteophyte too. And once we had removed the L4 osteophyte, the only thing we have left to do is to remove the compressing soft tissue. We are going to do this with a combination of coagulation and Kerrison punches and love punches. This is a way to shrink the soft tissue and then remove it with the Kerrison punch. And to finish, we will going to dissect a little of nerve root to make sure that there's no more soft tissue compression it. So here's the final view without osteophytes and without soft tissue compressing the nerve root. It's really nice to see the postoperative CT scan, especially in the sagittal plane, where you can see the restitute foramen. Here we had this osteophytes compressing the nerve root, and here there's an absence of compression that reflects in the patient's evolution. Here's the 3D reconstruction. So these lessons learned from the intralaminar axis expanded the indications of the transforaminal axis. We started to deal with a complex pathology like severe foraminal stenosis, listhesis, some recurrence from open surgery. You know, it's a nice strategy to, if you have a patient that had an open surgery from the midline, if you can solve the problem from the transforaminal axis, you avoid the whole fibrosis problem, and it's really satisfying for the patient and for the physician. Of course, we started to challenge ourselves and treat another kind of complications. Here is a case of a patient that was operated through open surgery. She had a cage between L4 and 5, and the cage migrated and started to compress the exiting nerve root. So what we did was an endoscopic approach that try to anchor the needle and the working sheet into the remains of the SAP. Here you can see the axis, and the idea was the same, to navigate from that safe zone to the foramen and identified the nerve root, the cage, and the remnants of the L5 SAP. And look at this. This is the same maneuver that we use in the interlaminar approach. This rotating maneuver with the working sheet allow us to mobilize the exiting nerve root and access the place where the cage was. And here's the cage exposure. You know, that's a peak cage. We are assessing mobility, and the cage wasn't mobile, so we had to remove some of the osteophytes covering the cage, and to gain some access, some direct access to the cage. And then we started drilling the cage to lower the volume of the cage until we reached like the metallic landmarks of the cage. The good thing is that when you diminish the volume of the cage and you unrotate the working sheet, you can see that the nerve root rests without compression of the cage. So this is the before and after photo of this patient. So this is an example how interlaminar technique affected and improved our transforaminal technique. Obviously, our improvement in techniques and technology didn't just ended with transforaminal access. We started to do some, I think that expanded indications for interlaminar access, just as you know, the just a facet cyst. I like this term because it's puts together like synovial cyst, ligamentum flavum cyst, and ganglion cyst. And you know, the discussion about this kind of cyst, it was that there's a wide variety of treatment available, and we started to see in the publications that fusion is only necessary when you have a previous instability. If you can go and just quietly and softly take out the cyst and maybe drill the facet in the exact attachment point of the cyst, the results are really good, and you don't have a posterior instability. And that's why endoscopic surgery it's really a good option from these patients. Here's a patient that had a synovial cyst arising from the L5S1 segment. You can see here how it compresses the S1 nerve root. On the right side, we have our standard interlaminar approach here with all the same technique that we use for a disc herniation, with only one difference. We in cyst, we like to expose the cyst from cranial to caudal to see the interface between the cyst and dura mater and nervous tissues. So we had here to widen the L5S1 interlaminar window. Here we have the final window, the one we widen, and this is the opening of the ligamentum flavum. You know, we do it really, really carefully with the scissors and the sectors, and then we start to see the attachment of the cyst to the dura. We are removing the ligamentum flavum cranial to the cyst, and we start to see how it's really attached even to the ligamentum flavum. And this is a maneuver I like so much. This is the mimic of the bimanual maneuver of dissection that we do in open surgery, but in endoscopic surgery. We have here a two-handed dissection maneuver. I don't know if you can see it in the video, but what I'm doing here is with my left hand, I am mobilizing my working sheet and using it as a dissector to move away the cyst and be able to coagulate the adherences of the dura and the cyst. Here we are coagulating and then dissecting really softly to avoid damage to the nervous tissues. We continue this process of coagulating and then removing. And here you can see how we coagulate the cyst and dissect. And there is something really interesting here. You know, when we did a open surgery, opening the cyst resulted in incomplete remotion because the cyst loses some shape. Here in endoscopic surgery, you have a continuous output of fluid, of water into the cyst. So even when you remove it piecemeal and empty the cyst, the capsule is still it's still full. So there's no inconvenience on emptying the cyst. It's really favorable because you can dissect it more easily. So here we are dissecting the cyst from the S1 nerve root and starting to reach the end of the surgery. That scissor technique has to be really delicate to avoid damage to the neurostructures. So here we are taking out the final part of the cyst, just peeling out the nerve root under endoscopic visualization, and then taking out with kerosene punches. And then we check with the X-ray if you are really in the caudal limit of the root of the cyst. And this is the final revision. You have the S1 nerve root totally free. You can mobilize it without any attachments, without any problems. And the thing is that when we do some control, some MRI control post-operative, we see the absence of the cyst, and not only the absence of the cyst, but the absence of damage to muscle and ligaments. The same muscle that the patient had before is the same that she had after the surgery. Obviously, when you look at the functional, the dynamics X-ray, 6 months post-operative, there's no instability. So what about doing some changes to the extraforaminal and foraminal access to the L5-S1 disc space? I told you before that this is a really troublesome space for us endoscopic spine surgeons because the access is not always simple. You had to avoid the high iliac crest. You had to avoid the sacrum promontory, and you had to avoid the transverse process of L5. And there's a new kind of approach, a relatively new kind of approach that is a contralateral interlaminar that allows us to treat lateral recess and foraminal pathology from the other side while using the same techniques that we learned in interlaminar approach. So here's a patient that had a combined pathology. He had a facet cyst and foraminal stenosis, 68 years old, really active, a marathon runner. He had an open discectomy 14 years ago that put a lot of scar tissue even in the L5-S1 disc space. And here's the MRI. You can see the foraminal stenosis and the synovial cyst. So what we plan here is to access that that space from the contralateral side to be able to treat both diseases at once with one approach. So this is the occluded foramen in the CT scan, and our approach was this contralateral interlaminar approach. We were aiming to first identify this angle, then go dissecting the ligamentum flavum and releasing the ligamentum flavum contralaterally, and finally accessing the attachment of the cyst into the SAP. Yeah, you know, the idea was to drill the exact amount of SAP necessary to prevent cyst recurrence, and then perform an adjusted foraminoplasty from the inside to release the L5 right nerve root. So this is the approach. We go a little further lateral than the usual interlaminar approach, go from lateral to medial, and then start to drill the ventral cortical surface of the lamina of L5. We release.
Excuse me, Doc, we have to wrap it up, okay, in a minute or so.
Oh, okay. Just going to the final conclusion. You have the possibility of perform cervical spine surgery if you translate your lesson learned to the cervical spine, and even if you have complications in the lumbar spine, if you refine your technique, you can go and perform some technical nuances like this one. This is I think that it's necessary only in cases when you have an open bridge. Here you can see the incidental durotomy, and you can perform. It's possible to perform. Let me see here. You can perform a suture of your incidental durotomy with an endoscopic technique. I mean, it's not for newcomers, but it's possible, and you can close your dural incidental durotomy from the outside to the inside with a suture. Okay, so the take-home message is that the endoscopic surgery that you heard like 20, 30 years before is not the same that we had today. It's evolving continuously. There's different generations of endoscopic techniques coexisting today. You can go to a center and maybe see still using methylene blue and doing transforaminal only. And you can go to another center and see more state-of-the-art endoscopic surgery. And the idea is that there's a limit of what you can do with technology, and you can buy the top technology. But that I think that the first and the most important limited is the ability of the surgeon that must be trained. This is the end. The idea is that revolutions in everything, not only in spine surgery, can be done with time or with blood, with mistakes, and we have to choose time. We have to take our own time to make the revolution happen. And that's the end. This is my city. This is Rosario, the birthplace of Lionel Messi and Che Guevara, and you're all invited if I can help you with anything that you want in endoscopic surgery. Thank you for the invite again.
Okay, Facundo, thank you very much. I hate to be in a rush, but we have another conference going on. Thank you very much, Facundo, and thanks